At the urgent care clinic, 3 people came in with lower back pain. The first is Jeff, a 26-year-old, who says his pain began 5 hours ago after trying to lift a 300-pound weight off of the floor at his local gym. He describes the pain as sharp and severe and says the pain goes down the back of his right leg and into his foot. Physical examination reveals a positive straight leg raise test on the right and a diminished right Achilles tendon reflex. Second is Beth, a 68-year-old who says she slipped and fell while walking in her kitchen yesterday. Her history includes a wrist fracture from a little over a year ago. Physical examination shows midline spinal tenderness to palpation. Finally, we have Harry, a 71-year-old male, who says his back pain has progressively worsened over the past month, keeping him up at night. He also reports increased urinary frequency. Back pain is a very common complaint, and one for which there are many potential causes. It can originate from the spinal cord, nerve roots, the vertebral column, the surrounding muscles, and ligaments, or even extraspinal structures, such as abdominal organs. Therefore, the causes of back pain can be subdivided into mechanical causes, such as muscle strain, spinal osteoarthritis, disc herniation, spinal stenosis, vertebral fractures, and osteoporosis, and non-mechanical causes such as bone metastasis, seronegative spondyloarthritis, and vertebral osteomyelitis. First, let's start with musculoskeletal causes. The vast majority of cases of back pain are considered non-specific musculoskeletal pain due to strained muscles or ligaments. These individuals have no sensory or motor deficits, and they typically complain about tenderness over the affected muscle or ligament. The treatment for these individuals is prescribing activity as tolerated, and NSAIDs for pain management. The next one is spinal osteoarthritis, which can be due to the natural aging process where the cartilage at the tips of bones wears down over their lifetime. It is associated with joint degeneration, ligamentous changes, disc degeneration, and finally, deformity of the spine. Next, we have disc herniation. Now, the spine is made up of bony vertebrae separated by intervertebral discs that act like cushions to absorb shock. The intervertebral discs consist of a thick, tough, fibrous outer ring called the annulus fibrosus, surrounding a soft gelatinous core called the nucleus pulposus. In disc herniation, the nucleus pulposus bulges outward, almost always posteriorly, since the posterior longitudinal ligament is relatively thin compared to the anterior longitudinal ligament. This is most often caused by an individual doing some heavy lifting, and while any disc in the spine can herniate, a high-yield fact to know is that it is almost always one of 2 discs in the lumbosacral region that herniates, the L4 to L5 disc or the L5 to S1 disc. But on rare occasions, the disc between L3 and L4 vertebrae can also herniate. Regardless of the disc that herniates, the nerve that is affected is typically below the level of herniation. A key symptom for L4 to 5 and S1 to 3 disc herniations is sciatica, or a shocking pain that shoots down from the buttocks through the leg, following the course of the sciatic nerve. In L4 radiculopathy, where the disc between L3 and L4 herniates, there's also motor deficits like weakness in knee extension and reduced patellar reflex. On the other hand, if the L4 to L5 disc herniates, it can result in L5 radiculopathy. These motor deficits include weakened hip abduction and foot dorsiflexion. Another high-yield point that you have to know for your exam is that individuals with L4 or L5 radiculopathy have difficulty in heel walking. Finally, if the L5 to S1 disc herniates, it can lead to S1 radiculopathy. Motor deficits include weakened foot plantar flexion and a diminished Achilles tendon reflex. Finally, remember that individuals with S1 radiculopathy have difficulty in toe walking. A common test used in diagnosing lumbar disc herniation is the straight leg raise test, or SLR, where a person laying on their back keeps their legs straight and then raises them one at a time between 30 and 60 degrees. If they experience pain radiating down their leg, the test is considered positive, suggesting lumbar disc herniation. An MRI of the spine can confirm the diagnosis. First-line treatment for disc herniation is usually conservative and involves rest with activity as tolerated, and NSAIDs to manage the pain. If that fails to manage pain, corticosteroids may be used. If symptoms persist or worsen beyond 6 weeks, treatment may involve surgical removal of part or all of the disc. Now, it's important to note that herniated disc can compress spinal roots below the L2 and cause cauda equina syndrome. Besides disc herniation, trauma and tumors can also cause this syndrome, which is characterized by back pain, radiculopathy, loss of bladder and sphincter control, and sexual dysfunction. For your exam, you have to know that cauda equina syndrome is associated with saddle anesthesia, which is a loss of sensation in the areas that would touch the saddle if you were to ride a horse. This includes the buttocks, inner surface of the thigh, and perineum. Also, one or both legs can be impaired by muscle weakness, loss of knee and ankle reflexes, and even paraplegia. A high yield fact to remember is that individuals with cauda equina syndrome require immediate surgical decompression via laminectomy to prevent permanent nerve damage. In addition, they can receive high doses of steroids to relieve the pain and reduce edema while waiting for the surgical intervention. Next is spinal stenosis, which refers to the narrowing of the spinal canal or intervertebral foramen, through which the spinal cord and spinal nerves pass respectively. Natural wear and tear or degeneration of the spine over time is the most common cause of spinal stenosis. Over time, osteophytes, or bone spurs, can form, and the ligamentum flavum can also grow excessively. All of these factors contribute to narrowing the spinal canal and intervertebral foramen, increasing joint stress and causing pain. Since the causative factors develop over time, it's typically found in individuals over the age of 60. The high-yield hallmark feature of spinal stenosis is neurogenic claudication, which refers to the pain being exacerbated by walking or standing upright, and it's relieved by sitting or bending forward. This is because walking or standing upright narrows the spinal canal and intervertebral foramen, while bending or leaning forward widens the spinal canal and intervertebral foramen. Pain relief when bending forward is often referred to as the shopping cart sign, because individuals typically bend forward when pushing a shopping cart, and this offers symptom relief. Key symptoms include back pain, which is usually the chief complaint. There could also be neurologic symptoms such as lower extremity numbness, tingling, or weakness if the stenosis results in compression of the spinal cord or nerve roots. Just like with disc herniation, sciatica can also present if nerve roots in the lumbar and sacral regions are compressed. Diagnosis typically involves a suggestive history, followed by a neurological exam and an MRI to confirm the diagnosis. Treatment is mostly conservative, involving physical therapy and pain management with NSAIDs, or epidural steroid injections in some cases. In rare cases, where spinal stenosis leads to compression of the spinal cords or spinal nerves, producing neurologic deficits, such as those in cauda equina syndrome, decompression surgery may be required. Next up are vertebral fractures, which are usually caused by major trauma that can lead to spinal cord lesion and eventual neural deficit. But for your exam, you have to know that vertebral fractures can also be asymptomatic, and in that case, you should think of compression fractures. A compression fracture is a subtype of vertebral fractures that is most commonly seen in individuals with osteoporosis. This is because individuals with osteoporosis, typically older postmenopausal women, have bones that are less dense, making them more susceptible to fractures. In the spine, the body of each vertebra losing density over time decreases their ability to withstand pressure that may occur even with normal movement, such as bending over, and fractures can develop. But it's important to note that minor trauma, such as slipping and falling, can also result in a compression fracture. Vertebral fractures can lead to kyphosis, or outward bending of the spine, and loss of height. It's usually after some minor trauma that an individual with a compression fracture will present with localized back pain. Diagnosis is dependent on a suggestive history followed by a physical exam looking for localized midline spine tenderness and an X-ray of the spine to confirm. Treatment is often conservative, involving bracing, pain management, and managing the underlying osteoporosis. In rare cases in which pain persists beyond 6 weeks, or if the fracture produces neurologic deficits, surgery may be indicated. Let's move on to back pain that is related to cancer, which is most commonly caused by bone metastases. For your exam, you have to know that cancers that commonly spread to the axial skeleton include prostate and breast cancers, then kidney, thyroid, and lung cancers. Another high-yield cause is multiple myeloma, which is the neoplastic proliferation of plasma cells within the bone marrow, which is most commonly seen in individuals over 60 years of age. When you think of multiple myeloma, think of the mnemonic CRAB, where C stands for hypercalcemia, R for renal involvement, A for anemia, and B for bone lytic lesions and back pain. A tumor in the spine can grow and push against the spinal cord, thereby causing spinal cord compression, which can lead to neurological symptoms and even permanent loss of neurologic function. The main symptom is often back pain that comes on gradually, progressively worsens, and is worst at night. The pain can be accompanied by constitutional symptoms such as night sweats, fever, chills, fatigue, malaise, or unintentional weight loss. Neurologic symptoms can include lower extremity weakness, numbness, bladder or bowel dysfunction, and even paralysis in severe cases. Diagnosis often involves an MRI, or CT instead in patients where an MRI is contraindicated. If the primary cancer is located, a biopsy is needed to identify the causative cancer, so treatment can begin. Next, we have seronegative spondyloarthropathies, which include inflammatory conditions that affect the vertebral column. These disorders are called seronegative because there's an absence of rheumatoid factor, or RF, which is most commonly found in rheumatoid arthritis. They also have a strong association with HLA-B27, which is an MHC class I molecule. For your exam, you have to know that seronegative spondyloarthropathies more commonly affect men, usually before the age of 45. Another high-yield point is that these individuals typically complain about slowly progressive lower back pain, especially around the sacroiliac joints. The pain is worse at night, and there's morning stiffness that lasts more than 30 minutes and improves with movement and exercise. Besides back pain, individuals with seronegative spondyloarthropathies can present with peripheral arthritis, enthesitis, which is an inflammation of the sites where tendons and ligaments insert into the bone, uveitis, which is an inflammation of the uvea, and dactylitis, which is an inflammation of the fingers, also known as sausage fingers. Now, there are several subtypes of seronegative spondyloarthropathies, and you can remember them with the mnemonic PAIR, where P stands for psoriatic arthritis, A for ankylosing spondylitis, I for inflammatory bowel disease, and R for reactive arthritis. First, let's start with psoriatic arthritis, which occurs in individuals with psoriasis. It's characterized by an asymmetric inflammation of the joints, primarily on the hands and feet, but also the spine. For your exam, it's important to note that less than 30% of individuals with psoriasis develop psoriatic arthritis. These individuals typically present with dactylitis and pencil-in-cup deformity on X-ray. Pencil-in-cup deformity occurs due to resorption of the terminal phalanges. With ankylosing spondylitis, there's a chronic symmetrical inflammation of the spine and sacroiliac joints that can lead to partial or even complete fusion of joints, or ankylosis. Now, ankylosing spondylitis is more commonly found in males, and for your exam, you have to know that these individuals can present with extra-articular features such as unilateral anterior uveitis, which occurs in 25% of individuals with ankylosing spondylitis, aortic regurgitation, and restrictive pulmonary disease due to costovertebral and costosternal ankylosis. Moreover, to assess the severity of the condition, it's crucial to monitor the chest wall expansion. X-ray features include ankylosing of sacroiliac joints, ankylosing of intervertebral joints, and bamboo spine. Bamboo spine occurs as a result of vertebral body fusion by marginal syndesmophytes, which are bony growths within the ligaments of the spine. The last one is reactive arthritis, which was formerly known as Reiter syndrome. This is an autoimmune condition that typically affects young men. It occurs after a bacterial infection of the gastrointestinal or urinary tract, and the most common microorganisms that are associated with reactive arthritis include Shigella, Yersinia, Chlamydia, Campylobacter, and Salmonella. Remember that these organisms are not invading into the joints, and the inflammation is autoimmune in nature. An easy way to remember them is to think of the mnemonic shy chicks. The classic triad seen in individuals with reactive arthritis consists of conjunctivitis, urethritis, and arthritis. So, for your exam, remember that these individuals can't see, can't pee, and can't climb a tree. And now finally, we move on to osteomyelitis. So this is not an autoimmune disorder, and the microorganisms are actually invading the bones, causing damage. If bacteria spread from a distant site through the bloodstream to vertebrae, then it's called vertebral osteomyelitis. This usually affects two adjacent vertebrae, and the intervertebral disc between them. Now, for your exam, you have to know that the most common causes of vertebral osteomyelitis are Staphylococcus aureus and Mycobacterium tuberculosis. Moreover, vertebral osteomyelitis caused by Mycobacterium tuberculosis is also referred to as pot disease. Individuals with vertebral osteomyelitis typically complain about back pain, fever, and night sweats, and it's easy to confuse this with metastasis to the spine. Laboratory findings such as elevated erythrocyte sedimentation rate, or ESR, and C-reactive protein, or CRP, are sensitive, but not specific enough. Therefore, we need to use imaging methods, such as X-ray and MRI. X-ray is insensitive in acute osteomyelitis, but it can be useful in the diagnosis of chronic osteomyelitis, while MRI stands to be the best imaging method for detecting acute infection and precise detection of affected vertebrae. Alright, as a quick recap, back pain is a very common complaint, and one for which there are many potential causes. It can originate from the spinal cord, nerve roots, the vertebral column, the surrounding muscles, and ligaments. Therefore, the causes of back pain can be subdivided into mechanical causes such as muscle strain, spinal osteoarthritis, disc herniation, spinal stenosis, vertebral fractures, and osteoporosis, and non-mechanical causes such as bone metastasis, seronegative spondyloarthritis, and vertebral osteomyelitis. Now, back to our patients. Jeff has sharp low back pain radiating down his leg and into his foot. So this is a case of sciatica. The symptoms started after he attempted to lift something heavy, and due to his young age, the most likely diagnosis is lumbar disc herniation. The positive straight leg test also suggests this. The diminished Achilles tendon reflex points specifically to L5-S1 disc herniation. An MRI of his spine can confirm the diagnosis. Beth's age, sex, past history of a wrist fracture all point to osteoporosis. The recent minor trauma from the fall that resulted in her current complaint of back pain is most likely due to osteoporotic vertebral compression fracture. The physical exam demonstrated midline spine tenderness localized to L4, and X-ray confirmed the diagnosis. Harry's age, sex, and description of progressively worsening back pain that is keeping him up at night, coupled with the urinary change of increased frequency, suggest prostate cancer that has metastasized to his spine. An MRI reveals blastic lesions to his lumbar spine, and labs reveal increased levels of prostate-specific antigen and alkaline phosphatase.
On your rounds, you see Ashvir, a 50-year-old man who complains of severe pain and swelling in his first toe on the right foot. This is the first time he's experienced this, and the symptoms developed in the last 5 hours. He has described the pain as very severe, and it's causing him to limp. On examination, he's obese and the toe is swollen, red, warm, and painful to the touch. Then you see Bianca, a 22-year-old who also came in with pain and swelling of the left big toe and left knee, which developed yesterday. However, unlike Ashvir, she is not overweight, yet does have a history of hemochromatosis. Synovial fluid analysis was performed in both, detecting negatively birefringent crystals in Ashvir and weakly positively birefringent crystals in Bianca. Now, both seem to have some type of crystalline arthropathy. But let's talk about physiology first. Purines, together with pyrimidines, are key components of nucleic acids like DNA and RNA. Purines are first broken down into adenosine monophosphate, or AMP, and guanosine monophosphate, or GMP. AMP is converted to inosine via two different mechanisms, either by removing an amino group to form inosine monophosphate, or IMP, which is quickly converted to inosine, or by removing a phosphate group to form adenosine, which is also converted to inosine. Inosine is then converted to hypoxanthine, and hypoxanthine to xanthine, which is finally metabolized to uric acid. These last two steps are catalyzed by the enzyme xanthine oxidase. GMP is converted to guanosine, which is then converted to guanine. Guanine is then deaminated to form xanthine, which is oxidized by xanthine oxidase to form the final product, uric acid. Now, under normal physiologic conditions, uric acid circulates in plasma and synovial fluid as urate anions. However, human tissues have a limited ability to metabolize urate. Thus, it is quickly eliminated by the kidney and the gut to maintain urate homeostasis. Another way the body can avoid excess uric acid is by recycling purines via the purine salvage pathway. This is when organs convert hypoxanthine back to IMP via hypoxanthine guanine phosphoribosyltransferase, or HGPRT, which then gets converted to AMP to make new purines. Conversely, we can take guanine and convert it to GMP by HGPRT to make new purines. Now, gout is a monoarticular inflammatory disease where monosodium urate crystals cause joint damage. When plasma becomes saturated with urate acid molecules, these bind sodium to form monosodium urate crystals, especially in areas with slow blood flow, like the joints and the kidney tubules. Okay, so the main risk factor for gout is excess uric acid, or hyperuricemia, and it can be caused by many things. First is underexcretion of uric acid by the kidney, which can be idiopathic, or when the cause is not known, due to renal failure, or it can be exacerbated by medication, like thiazide diuretics and aspirin. Second is overproduction of purines. This can occur with increased consumption of purine-rich foods, such as shellfish, anchovies, and red meat. High fructose corn syrup containing beverages can contribute to hyperuricemia too, usually by increasing purine synthesis. Also, these kinds of foods and drinks can lead to obesity and diabetes, both of which are risk factors for gout, alongside male sex, hypertension, dyslipidemia, and alcohol use. Others might have a genetic predisposition to overproduction of uric acid, or it can develop as a result of chemotherapy or radiation treatment, where a lot of tumor cells die, causing what is known as tumor lysis syndrome. The syndrome occurs because dead cells release their contents into the bloodstream, resulting in increased levels of potassium, causing hyperkalemia, phosphate causing hyperphosphatemia, and uric acid, leading to hyperuricemia. Finally, there are some rare causes of uric acid overproduction that are high yield. For example, Lesch-Nyhan syndrome is an X-linked genetic disorder leading to HGPRT deficiency, which results in buildup of uric acid in all bodily fluids secondary to decreased purine recycling. Then we have phosphoribosyl pyrophosphate synthetase excess, caused by an X-linked genetic defect in the enzyme. Because it is involved in purine production, and because it acts as a substrate used by HGPRT during purine salvage, the enzyme's excess results in increased de novo synthesis and decreased recycling of purines. A final one is von Gierke disease, a condition in which the body cannot break down glycogen due to glucose 6-phosphatase deficiency. As a result, glucose 6-phosphate can't be converted to glucose, impairing gluconeogenesis, which is the process by which the body produces glucose from non-carbohydrate precursors. This causes pyruvate, a non-carbohydrate precursor, to accumulate, preventing the conversion of lactate into pyruvate. This causes lactate to build up, causing lactic acidosis. Since lactic acid competes with uric acid for transport in the renal tubules, uric acid excretion decreases, so it also builds up in the body. Now, moving on. The problem with these crystals accumulating in soft tissues and joints is that they can cause tissue damage and a self-limited acute inflammatory episode called a gout attack. Although the mechanism is not fully known, it is thought that the crystals interact and activate monocytes and macrophages, which try to clear them by phagocytosis. This leads to the release of pro-inflammatory cytokines like TNF-alpha, interleukin-8, and other chemokines into the surrounding area, triggering the inflammatory reaction and an influx of neutrophils into the joints, resulting in joint damage and symptoms of acute gout. These episodes resolve spontaneously in around 10 days, possibly mediated by anti-inflammatory cytokines. Over time, repeated acute gout episodes can develop into chronic gout, which is a type of arthritis with joint tissue destruction and permanent joint deformity. Chronic gout can eventually lead to permanent deposits of urate crystals, called tophi, which form along the bones just beneath the skin. Microscopic tophi can be walled off by a ring of proteins, which blocks their interaction with immune cells and therefore do not trigger an inflammatory response. Sometimes, though, some of these crystals can get past the wall and trigger new gout attacks, which brings further destruction to the joint. Individuals with chronic gout are also at an increased risk for developing kidney stones made of uric acid, as well as urate nephropathy, which is when urate crystals deposit into the interstitium of the kidney. Now, symptoms of gout are high yield and frequently tested, and they depend on which joint is affected and if the presentation is acute or chronic. Okay, so the disease is usually symmetrical and affects the first metatarsal joint of the foot or the base of the big toe, but the joints of the ankles, knees, wrists, and elbows can also be involved. When it involves the big toe, this condition is called podagra. Classically, in an acute gout attack, individuals feel sudden pain over the affected joint that's so severe it even wakes them up from sleep feeling like their big toe is on fire. People describe this pain as the worst pain they've ever had. But fortunately, the pain generally lessens over time. And because it is an inflammatory process, the affected joint is also swollen, warm, and red. Occasionally, a gout attack triggers a systemic inflammatory response, manifesting with fevers, leukocytosis, elevated sedimentation rates, and elevated C-reactive protein, or CRP. Something else to know is that the acute attack tends to occur after a large meal, with foods rich in purines, trauma, surgery, dehydration, and diuresis. They can also be triggered by alcohol consumption, because alcohol metabolites compete for the same excretion sites in the kidney as uric acid, causing decreased uric acid excretion. Chronic gout, on the other hand, can be asymptomatic between gout attacks, which can occur quite frequently if the cause of hyperuricemia is not dealt with. The clinical picture is dominated by the presence of tophi around the affected areas. Sometimes these tophi can develop in unexpected places, like the external ear, olecranon bursa, or Achilles tendon. If, in time, people develop uric acid kidney stones, they might present with symptoms like lumbar pain that radiates to the lower abdomen and groin, pain on urination, and hematuria. If clinical symptoms suggest gout, diagnosis is based on elevated serum urate levels and synovial fluid analysis. Synovial fluid analysis is when synovial fluid is extracted with a syringe from the affected joint and then analyzed on a microscope for increased white blood cell count with a neutrophil dominance and the presence of monosodium urate crystals. A high-yield fact is that on a microscope, under polarized light, monosodium urate crystals can be both inside and outside the cells, have a sharp needle-like form, and are negatively birefringent. Negative birefringence means they are yellow under parallel light and blue under perpendicular light. In addition, the fluid should be examined by gram stain and culture, especially if no crystals are found, to exclude infection as a possible cause for the symptoms. Next, because serum uric acid levels can be normal during a gout attack, and monosodium urate crystals can be absent on synovial fluid analysis, an X-ray or CT of the affected joint is needed. Imaging can detect crystal deposits and well-defined erosions with sclerotic margins and overhanging edges, which usually occur in chronic gout. Treatment of gout is also high yield. First-line treatment in a gout attack is nonsteroidal anti-inflammatory medications, or NSAIDs, like ibuprofen or naproxen sodium. NSAIDs work by inhibiting cyclooxygenase enzymes, thus decreasing prostaglandin production, resulting in decreased inflammation. However, these drugs should be avoided in those with liver and renal dysfunction. Second-line medication includes colchicine. Colchicine binds to the protein subunit of the neutrophil's microtubules, which are part of the cellular cytoskeleton, and prevents microtubule assembly. This, in turn, disrupts membrane-dependent functions like leukocyte migration and phagocytosis. This means that neutrophils won't be able to come at the site of the injury and process monosodium urate crystal, and subsequently cause gout attack symptoms. Keep in mind that colchicine is not preferred over NSAIDs due to its side effects, which include nausea, abdominal pain, and diarrhea. It should also be avoided in the elderly or those with renal dysfunction. Occasionally, corticosteroids can be used as an alternative to NSAIDs and colchicine. It's also important to treat the underlying cause of increased uric acid, though individuals should modify their diet by eliminating soda, alcohol, red meat, and seafood. It also helps to stay hydrated and stay active to ward off obesity. There are also medications that help to decrease uric acid levels, which are indicated in chronic gout or as a preventative method, but they are not helpful during an attack. These should be initiated if there are macroscopic tophi, more than 3 gout attacks per year, uric acid kidney stones, and significant hyperuricemia. The most high-yield medications include xanthine oxidase inhibitors, like allopurinol and febuxostat, which decrease uric acid production by inhibiting xanthine oxidase. Allopurinol can be used in the prevention of tumor lysis syndrome as well, and it can increase the toxicity of azathioprine if used together. This is because xanthine oxidase catalyzes one of 2 major azathioprine inactivating pathways. Allopurinol completely inhibits xanthine oxidase, which results in increased conversion of azathioprine to its active metabolite. The second most common option is uricosuric medications, like probenecid, which increases excretion of uric acid by the kidneys. Low doses of colchicine can also be used to prevent a gout attack. Okay, let's move on to the next disease, which is calcium pyrophosphate deposition disease, or CPPD, previously known as pseudo-gout. This is a crystal arthropathy associated with those over 50 years old. Although the pathogenesis of CPPD disease is not as well understood, similarly to gout, there is probably excessive pyrophosphate production, resulting in calcium pyrophosphate supersaturation and the formation of CPPD crystals. These accumulate in the joints and soft tissue, where they can cause inflammation and tissue damage. Now, the condition is usually idiopathic, meaning its cause is unknown, and it can be associated with certain underlying diseases like trauma to the joint, hyperparathyroidism, hypomagnesemia, hypothyroidism, hypophosphatasia, and hemochromatosis, which is an abnormal accumulation of iron in parenchymal organs. The clinical symptoms of CPPD during an acute attack can be indistinguishable from acute gout, where the affected joint is painful, swollen, warm, and red. Now, although CPPD disease and gout can affect the same joints, CPPD disease tends to affect more than one joint, usually larger joints like the knee. Other joints that can be affected include the elbow, shoulder, and wrist joints. And just like gout, it can also lead to chronic degeneration with joint destruction and limited joint mobility. Since the symptoms are similar to gout, the definitive diagnosis requires synovial fluid analysis. CPPD crystals might not be as evident as monosodium urate crystals, as they are weakly positively birefringent under polarized light, which means they have the opposite pattern seen in gout. They are blue under parallel light and yellow under perpendicular light. They also have a rhomboid or rod-shaped appearance and can be seen either in or outside the cell. In addition, because CPPD disease and gout can coexist, monosodium crystals might be observed as well. Next, imaging can help confirm the diagnosis if fluid analysis is inconclusive, and it typically shows chondrocalcinosis in the joint involved, which is cartilage calcification. Chondrocalcinosis can occur even if the disease is not clinically active at the time of presentation. And because CPPD disease is associated with a variety of underlying conditions, screenings for hyperparathyroidism, hypothyroidism, hypomagnesemia, hypophosphatasia, and hemochromatosis are also necessary. Regarding treatment, acute attacks can be managed with NSAIDs, colchicine, and glucocorticoids. Prophylaxis is done with colchicine. Unlike gout, however, there are no hypouricemic equivalents to improve the long-term control of acute attacks or to prevent or reverse CPPD disease. All right, as a quick recap, gout is a type of inflammatory disease that typically affects the first metatarsal joint, which is the base of the big toe, where uric acid precipitates to form monosodium urate crystals, which deposit in the joint and lead to inflammation and pain, redness, warmth, and edema. Over time, chronic gout can lead to bone erosion. Diagnosis is based on synovial fluid analysis, where monosodium urate crystals have a sharp, needle-like form and are negatively birefringent. CPPD is caused by calcium pyrophosphate crystal accumulation in the joint, which results to a similar clinical picture as gout. The disorder is more likely to affect multiple joints and are more common in larger joints like the knees. Diagnosis is based on synovial fluid analysis as well, where CPPD crystals are weakly positively birefringent and they have a rhomboid or rod-shaped appearance. Okay, now back to our cases. Ashvir comes in with the classic presentation of a gout attack, a severely painful right big toe with signs of inflammation like redness, swelling, and warmth. He is also obese, which is a risk factor for gout. Our suspicion was confirmed by synovial fluid analysis, which detected monosodium urate crystals. Bianca's symptoms painted a similar picture. However, her history of hemochromatosis makes us think of CPPD and not gout. This suspicion was confirmed by the weakly positively birefringent crystals found on synovial fluid analysis, which are characteristic of this condition.
At the clinic, 32-year-old Mary comes with her 6-year-old son Thomas after noticing he's often clumsy, weak, and has trouble climbing the stairs of their house. Mary is worried because she had a brother who presented the same symptoms when he was a child and developed progressive weakness until he passed away at 23 years old due to respiratory problems. Upon physical examination, the physician notices that Thomas has scoliosis and thick calves. Later that day, 29-year-old Sarah comes to the clinic with her 10-year-old son Mike because of progressive muscle weakness and fatigue, as well as vomiting and loss of appetite. In addition, she mentions that he has experienced seizures. Based on the clinical findings, the physician concludes that both children have some form of inherited muscular disorder and orders genetic testing to confirm the diagnosis. Now let's go over the two main groups: muscular dystrophies and mitochondrial myopathies. Muscular dystrophies are a group of genetic disorders characterized by muscle degeneration and weakness. Within that group, dystrophinopathies are the most common, and this includes Duchenne muscular dystrophy, or DMD for short, and Becker muscular dystrophy, or BMD. Both Duchenne and Becker result from mutations in the dystrophin gene, which is found on the X chromosome. For your exams, remember that these are X-linked recessive disorders, which means that all carrier males develop the disease because they only have one chromosome and thus one dystrophin gene available. On the other hand, females have two X chromosomes, so even if they have a defective dystrophin gene on one X chromosome, they still have another functional one. However, only one X chromosome gets expressed, and the other is inactivated through a process called X inactivation, or lionization. This inactivation is random, which means that every cell could have a chance of having the mutated X chromosome be the active copy. If this is the case for more than half of the muscle cells, they will be a manifesting carrier who will develop symptoms. People with more cells with the active mutated X chromosome will have more severe symptoms and quicker disease progression. If less than half of their cells have the active mutated X chromosome, they'll be an asymptomatic carrier and won't develop symptoms. Now, long story short, dystrophin is a protein found on the plasma membrane of muscle fibers to provide mechanical reinforcement and stabilization. As a result, having defective dystrophin proteins leads to degeneration and instability of muscle fibers, in turn causing muscle weakness. What determines which disease you get is the type of mutation in the dystrophin gene. Duchenne muscular dystrophy happens when the mutation results in no protein being produced at all, for example, a nonsense or a frame shift mutation. On the other hand, Becker muscular dystrophy results from mutations like missense mutations that allow a misshapen and partially functional protein to be produced. So what's especially high yield is that Duchenne ends up being the more severe of the two, with symptoms usually presenting by the age of 5, while Becker is basically a milder form of Duchenne that presents later on, usually between the ages of 10 to 20. In both disorders, initially, there's muscle regeneration to compensate for the muscle degeneration and weakness. Over time, however, the muscle tissue can't keep up, so it atrophies and gets infiltrated by fat and fibrotic tissue. This process can occur in any muscle, but it is most noticeable in the muscle of the legs. In a test question, this will classically manifest as calf pseudohypertrophy, where the calves are visibly enlarged, but that's because of fat and fibrotic tissue rather than actual muscle tissue. As muscle weakness progresses, individuals have progressive difficulty walking. A very high-yield sign is the waddling gait. This is due to the pelvic girdle muscles becoming weak, so the individual will have problems with balance. So, to compensate, they will walk by taking short steps while swinging their trunk side to side with each step as a counterbalance. Muscles around the hips and upper legs can also weaken, making it hard for these individuals to stand up. Now, an important term to remember is Gower's sign, which is when an individual that's lying on their stomach needs to use their arms to slowly walk back up in order to stand. Individuals can also develop skeletal deformities like scoliosis and hyperlordosis. As muscle weakness progresses, most individuals with Duchenne may end up needing a wheelchair by the age of 13 and can become paralyzed from the neck down by the time they're 21 years old. On the other hand, for individuals with Becker, this progression is usually delayed by about 10 years. Eventually, individuals end up developing serious complications, including respiratory failure because of a weak diaphragm, and dilated cardiomyopathy and arrhythmias, since the dystrophin protein is also expressed in heart muscle. Unfortunately, these complications often lead to a shortened lifespan. Most individuals with Duchenne die in their 20s, and those with Becker in their 40s. For diagnosis, people with suspected Duchenne or Becker muscular dystrophy on physical examination should get appropriate testing. The first step is getting blood tests for creatine kinase, or CK. If CK levels are high, diagnosis can be confirmed through genetic testing that looks for mutations in dystrophin either with a Western blot test or DNA tests. Rarely, if genetic testing is inconclusive, a muscle biopsy with staining for dystrophin will be required. Remember that we expect to see an absence of dystrophin in Duchenne and abnormal dystrophin in Becker. Unfortunately, there is no cure for muscular dystrophies. Glucocorticoids can sometimes slow degeneration, but they should be used in moderation since they are typically also accompanied by side effects like excessive weight gain. Other treatments like physical therapy and conditioning can improve quality of life, but they don't reverse the underlying process. Alright, now, another form of inherited muscular disorder is mitochondrial myopathies, which are a group of inherited neuromuscular disorders that are characterized by dysfunctional mitochondria with the inability to produce enough ATP. The most affected tissues include the brain and muscles, since these are the ones that require the highest levels of ATP. Some of the mitochondrial proteins involved in the electron transport chain are encoded by the mitochondrial DNA, while others are encoded by the nuclear DNA. So what's high yield is that most mitochondrial myopathies are caused by mutations in the mitochondrial DNA, which follows maternal inheritance. This is because during fertilization, the father's mitochondria are left behind while the sperm's nucleus alone enters the egg. For your exams, it's important to note that since mitochondrial DNA is maternally inherited, only biological females can pass mutations to their children. Another high-yield fact is that mitochondrial inheritance shows heteroplasmy, which means that each cell contains hundreds of mitochondria with hundreds of copies of different mitochondrial DNA. As a result, mutations in mitochondrial DNA will only affect some mitochondria, leaving the rest unaffected. And the resulting mitochondrial myopathies can have variable clinical presentations and severity, ranging from mild to fatal disease. Now, the main clinical features of mitochondrial myopathies include fatigue, myalgia, eye-related symptoms like vision loss, ptosis, and ocular dysmotility, and neurological symptoms like seizures, hearing loss, impaired coordination, and cognitive deficits. For your exams, the most important mitochondrial myopathy to know about is MELAS syndrome, which is an acronym for its main symptoms: mitochondrial encephalomyopathy, lactic acidosis, and stroke-like episodes. The onset of MELAS is typically during childhood. Early symptoms can include fatigue and exercise intolerance. Most individuals with MELAS develop lactic acidosis due to lactic acid buildup in their bodies. Lactic acidosis can lead to fatigue, muscle weakness, abdominal pain, vomiting, and difficulty breathing. Additionally, before the age of 40, most individuals present with stroke-like episodes involving altered consciousness, hemiparesis, or muscle weakness on one side of the body, and hemianopia, or vision abnormalities on one side of the visual field. In addition, individuals may present with severe headaches and seizure, develop visual and hearing loss, and weight loss. Over time, repeated stroke-like episodes can cause progressive damage to the brain, ultimately leading to blindness, movement problems, and dementia. Less frequently, individuals with MELAS can develop hearing loss, involuntary muscle spasms, cardiomyopathy, kidney problems, and diabetes mellitus. Now, diagnosis for mitochondrial myopathies begins with a physical and neurological examination, followed by blood tests that may show elevated levels of lactate and creatine kinase in the blood. To confirm diagnosis, genetic testing is done to look for mutations in the genes coding for the electron transport chains, either in the mitochondrial or in the nuclear DNA. Finally, if genetic testing is inconclusive, individuals may require a muscle biopsy. For your exams, keep in mind that this has to show ragged red fibers in Gamori trichrome staining, indicating that there's compensatory proliferation of abnormal mitochondria in the affected muscles. There is no cure for mitochondrial myopathies, but there are treatment options. Individuals may benefit from regular exercise as well as vitamins and supplements. Alright, as a quick recap. Muscular dystrophies include the X-linked recessive disorders Duchenne muscular dystrophy, which is caused by mutations that lead to a loss of dystrophin, and Becker muscular dystrophy, which is caused by mutations that lead to a misshapen or abnormal dystrophin. Individuals present with progressive muscle atrophy, calf pseudohypertrophy, difficulty walking, waddling gait, Gowers' sign, and skeletal deformities. Eventually, respiratory muscles and the heart become affected, leading to death. Most individuals with Duchenne develop symptoms by the age of 5, while Becker tends to develop later, between the ages of 10 and 20. Diagnosis is based on physical examination, blood tests showing high CK levels, genetic testing, and rarely, muscle biopsy. Mitochondrial myopathies are neuromuscular disorders that are most often caused by mutations in mitochondrial DNA, which leads to the inability to produce enough ATP by mitochondria. Since mitochondrial inheritance shows heteroplasmy, the resulting mitochondrial myopathies can have variable clinical presentations and severity. The main clinical features include fatigue, myalgia, eye-related symptoms, and neurological symptoms like seizures, hearing loss, impaired coordination, and cognitive deficits. An important mitochondrial myopathy is MELAS syndrome, which presents with mitochondrial encephalomyopathy, lactic acidosis, and stroke-like episodes. Diagnosis of mitochondrial myopathies includes physical and neurological examination, followed by blood tests that may show elevated levels of lactate and creatine kinase. Diagnosis can be confirmed through genetic testing. Finally, some individuals may need muscle biopsy, which will show ragged red muscle fibers. Now, back to our cases. The key to diagnose these disorders is to recognize their characteristic clinical findings. Thomas is a 6-year-old boy that presents with clumsiness, weakness, and trouble climbing stairs. The key clues were the calf pseudohypertrophy and the family history of similar symptoms. These point to an inherited muscular dystrophy. Due to the young age when symptoms manifested, it's more likely to be Duchenne and not Becker muscular dystrophy. On the other hand, Mike is a 10-year-old boy who presents with progressive muscle weakness, fatigue, vomiting, and episodes of seizures. The systemic symptoms, and especially the seizures in combination with progressive muscle weakness, point to MELAS. In both cases, genetic testing confirmed the suspected diagnosis.
On your rounds, you see two individuals. First is Yu Yan, a 58-year-old female who presents with a 2-week history of fatigue, weight loss, fevers, and bilateral pain with stiffness in the shoulder and hip girdles. These symptoms are worse at night and last for more than an hour. She also mentions that she finds it hard to get out of bed in the morning due to stiffness. On examination, her wrists and finger joints are painful and swollen, but there's no muscle weakness. Then you see Elizabeth, a 38-year-old female who has a 4-year history of body pain. The pain was initially limited to her neck, but it has gradually spread, and she now complains of constant pain all over. She doesn't sleep well and is chronically fatigued. Examination revealed many tender points throughout her body, but no sign of joint swelling or muscle weakness. Blood tests were performed in both. In Yu Yan's case, there was an increase in inflammatory markers, but creatine kinase levels were normal. In Elizabeth's, blood tests were completely normal. Both people have myalgias, or muscle pain. There are many causes, but let's start with myopathies, which are neuromuscular disorders in which the primary symptom is muscle weakness due to muscle cell dysfunction. There are two main inflammatory myopathies, polymyositis and dermatomyositis. First, polymyositis is an autoimmune disease where there's inflammatory infiltration in striated muscles that cause muscle damage. Now, the cause is still unknown, but polymyositis is often associated with other autoimmune diseases, including Sjogren's syndrome, rheumatoid arthritis, scleroderma, and mixed connective tissue disease. It is thought that there's an overexpression MHC class I molecules and muscular autoantigens, which end up triggering a primarily cell-mediated immune response that inappropriately activates CD4 positive and CD8 positive T cells. This is probably due to molecular mimicry, which is when an immune cell mistakes a protein in the body as being foreign due to their similar structure. Sometimes, humoral immunity can also kick in when B cells get activated by the autoantigens and make antibodies against them. These include histidyl tRNA synthetases, also called Jo1, a helicase protein known as Mi2, and components of the signal recognition particle, or SRP for short, which helps with protein trafficking within the cell. The bottom line is that these two immune reactions result in inflammation in and around the muscles that are being attacked. Attacks which occur repeatedly over time and can involve different muscle groups. Symptoms of polymyositis include progressive and bilateral weakness and muscle wasting. Weakness usually develops slowly over weeks to months, and its intensity can vary from mild to near paralysis. Sometimes the affected muscles can be tender or painful due to inflammation. Now, the disease mostly affects proximal, big muscle groups like the shoulder or hips, and it usually spares distal muscles like those in the hands and feet. As a result, individuals might have difficulties doing things like getting up, lifting their arms, and climbing stairs. In this case, you should know that Gower's sign might be present, which is when people use their arms to help them stand up from a squatting position or when getting up from a chair. Classically, this is a sign of Duchenne muscular dystrophy, but it can also be seen in inflammatory myopathies including polymyositis and dermatomyositis. Neck flexors are also commonly affected, resulting in neck pain and weakness. When the muscles of the pharynx or esophagus are involved, it causes dysphagia, or difficulty in swallowing. Sometimes the diaphragm and intercostal muscles can be weakened, which causes difficulty breathing, and this is made worse because inflammatory myositis is often accompanied by interstitial lung disease, where the parenchyma of the lungs undergo fibrosis and scarring. Sometimes the cardiac muscles are also affected. Although this is usually asymptomatic, it can result in conduction disturbances, myocarditis, or congestive heart failure. Diagnosis is based on identifying a variety of serum autoantibodies, such as anti-nuclear antibodies and myositis-specific antibodies, like anti-Jo1, anti-MI2, and anti-SRP. Next, remember there's elevated serum levels of muscle enzymes such as aldolase or creatine kinase, which are released when muscles get damaged. Additionally, electromyography can be used to detect regions of dead muscle cells that cause abnormal electrical signals conduction. Another high-yield diagnostic tool is muscle biopsy, and it can show inflammatory infiltrates mainly composed of CD8 positive T cells, macrophages, and varying stages of necrosis. Other pathologic findings can include endomysial infiltration by mononuclear cells, endomysium being the thinner portion of the intramuscular connective tissue that surrounds every single muscle fiber, capillary obliteration, overexpression of MHC class I molecules on the muscle cell's sarcolemma, and increased amounts of connective tissue. Pulmonary function tests can be used when there's suspicion of respiratory involvement, usually detecting a restrictive pattern if there's interstitial lung disease. Treatment of polymyositis typically focuses on suppressing the immune response, usually with corticosteroids. In addition, specialized exercise therapy can help maintain muscle function. Dermatomyositis is another autoimmune disease where the immune system attacks its own muscles, but this time it also affects the skin. The exact trigger for dermatomyositis is unknown. However, there are a few suspected genetic and environmental factors associated with the disease, like infection with Coxsackie virus or specific tumor antigens, such as those in ovarian, lung, or breast tumors. In dermatomyositis, it is believed that autoantigens in endothelial cells lining the capillaries in muscle and skin cells trigger a humoral immune response. The resulting autoantibodies attach to the endothelial cells lining the capillaries near the perimysium and activate the complement cascade, which, in turn, leads to the formation of a membrane attack complex that damages the endothelial cells. Now, antibodies also bind to small soluble autoantigens, like nuclear or cytoplasmic fragments resulting from cell destruction, and form antigen-antibody complexes. Small antigen-antibody complexes are not very immunogenic, so they don't get removed from the bloodstream very quickly. As a result, the complexes persist, and they reach the basement membrane of various blood vessel walls, once again activating the complement and causing damage. Cell-mediated immunity can also be involved, and it's usually associated with activated CD4 positive T cells, which cause further damage while also infiltrating the surrounding muscle and skin tissue. Okay, so the bottom line is that inflammation and cellular destruction result in the loss of blood vessels, which causes tissue ischemia and necrosis in the affected muscle and skin tissues. Symptoms of dermatomyositis are similar to those in polymyositis, except there's also skin manifestations. When there's muscle damage, there can be bilateral weakness, muscle atrophy, and muscle pain and tenderness that mostly affects proximal, big muscle groups, like the shoulder or hip. In severe cases, the muscles of the pharynx or esophagus can be affected, causing dysphagia and aspiration pneumonia. Now, a high-yield concept that you need to know for your exams is that unlike polymyositis, the skin is also involved. One classic finding is a purplish rash on the upper eyelids, called a heliotrope rash, which is named after a purple flower. A similar rash can involve the shoulders, upper chest, and back, resembling a shawl. Another sign is a malar rash, in the shape of a butterfly, on both cheekbones and the nasal bridge. Another classic finding is Gautron's papules, which are red, often scaly, bumps overlying the knuckles of the fingers. These rashes can be photosensitive, meaning they worsen when exposed to sunlight, and are itchy and painful. Individuals might also present with irregular, darkened thickening of the fingers, and these make the hands look like they're covered in grease or oil, and it's called mechanic's hands. One last thing to remember is that although dermatomyositis doesn't cause cancer, it's associated with an increased risk of hidden malignancy, like ovarian, lung, and stomach cancers. So remember to keep an eye out for people with dermatomyositis who also develop nonspecific symptoms like fever, night sweats, and weight loss. The diagnosis of dermatomyositis is similar to that of polymyositis, but it's based on the combination of skin and muscle findings. Typically, there are nonspecific autoantibodies, like anti-nuclear antibodies, or ANA, and myopathy-specific antibodies, like anti-MI2 and anti-Jo1. There can also be increased levels of muscle enzymes, like creatine kinase, and abnormal findings on an electromyograph. A muscle biopsy might show signs of muscle atrophy and perimysium inflammation with CD4-positive T cells. Treatment typically focuses on suppressing the immune response, usually with corticosteroids, such as prednisone. Anti-malarial medications such as hydroxychloroquine and chloroquine are sometimes effective in the management of skin rashes, along with sun avoidance and wearing protective clothing. Let's now switch to polymyalgia rheumatica, an autoimmune rheumatic disease resulting in severe joint stiffness and pain. Now, the cause is not well understood, but it seems to be associated with both genetic and environmental factors. For example, those with a certain gene for MHC class II molecules, also called a human leukocyte antigen, or HLA-DR4, are more likely to develop the disease. This is especially true after an infection with adenovirus or parvovirus B19, most likely due to molecular mimicry. Polymyalgia rheumatica is also strongly associated with giant cell arteritis. This is a condition where there's granulomatous inflammation of the walls of the arteries, especially in the branches of the carotid like the superficial temporal artery, which is why the disease is also called temporal arteritis. Additionally, it is thought that the resulting autoantigens trigger both a humoral and cell-mediated immune response. The autoantibodies and the activated T cells enter the circulation and end up reaching the large joints, where they ultimately lead to joint inflammation. Now, symptom-wise, the disease often affects women over 50 years of age. Something high yield is to keep in mind that although it's called polymyalgia, the muscles themselves are not inflamed or weakened and actually appear normal on biopsy. However, there might be muscle pain, mostly resulting from damage to the structures surrounding the joints, like the tendons and bursa, which affects nearby nerves in the muscle. In this case, it's called referred pain. Typically, polymyalgia is characterized by pain and stiffness of the shoulder and hip, which start as one-sided and then progress to both sides within weeks. Symptoms are more severe in the morning and at night. They last more than 45 minutes and improve after activity. They can also make it hard to get out of bed or up from a chair, as well as lifting the arms above shoulder height. Sometimes, inflammatory cytokines can travel through the bloodstream and reach other organs and cause additional symptoms. For example, interleukin-1 and interleukin-6 travel to reach the brain, where they act as pyrogens, inducing fever. Other symptoms can include fatigue and loss of appetite, which can lead to weight loss. Also, those with associated temporal arteritis can present severe unilateral headache, jaw pain while chewing, vision problems, and even blindness on the affected side due to occlusion of the ophthalmic artery. The diagnosis of polymyalgia rheumatica can be confirmed by increased inflammatory markers, like a high erythrocyte sedimentation rate, or ESR, and C-reactive protein, or CRP. Since there is little damage to the muscles, muscle enzymes like creatine kinase usually remain normal, which distinguishes polymyalgia rheumatica from other inflammatory muscle disorders, like polymyositis. X-rays of the affected joints can show signs of non-erosive joint disease. Treatment focuses on suppressing the immune response, usually with low doses of corticosteroids like prednisone. Specific exercises and a healthy diet can also help strengthen the muscles and bones, as well as improve flexibility of affected joints. Giant cell arteritis requires high-dose corticosteroids prior to temporal artery biopsy to prevent blindness. And the last disorder is fibromyalgia, a chronic condition that causes widespread muscle pain and tenderness in various parts of the body, alongside sleep disturbances, chronic fatigue, and mood disorders. The condition is common in women 20 to 50 years old, and it tends to run in families, which suggests a genetic component, while environmental factors like psychological stress, depression, trauma, child abuse, and infection might also contribute to its development. Actually, its pathophysiology isn't well understood, but unlike the other diseases we covered, there doesn't seem to be any damage to the muscles or joints. The problem is due to how the brain receives pain signals. Generally speaking, the affected individuals seem to have low levels of serotonin, which is involved in inhibiting pain signals, as well as elevated levels of substance P, which is involved in propagating pain signals. Together, these are thought to cause hypersensitivity to pain, which hints that fibromyalgia might be a condition that affects the central nervous system, causing what's known as central sensitization syndrome. The syndrome might also cause other types of sensitivities affecting everything from how individuals sleep, to how they feel, to how they think. You also need to keep in mind that the symptoms and diagnosis of fibromyalgia go hand in hand, as diagnosis is usually established on a clinical basis. First, there's widespread pain in at least 4 regions of the body. There are also tender points in the body. These points are symmetrically distributed over the individual's muscles, joints, and tendons, like the spine of the scapula or the lateral epicondyle of the femur. Although the number of tender points used to be part of the diagnostic criteria, it is not considered relevant anymore. And because the neurochemical abnormalities that occur in fibromyalgia also regulate mood, sleep, and energy, symptoms related to mood, sleep, and fatigue problems are common in fibromyalgia. For example, some might have difficulty concentrating and remembering things, sometimes called fibrofog, while others might have poor sleep and might wake up unrefreshed and having a headache. Typically, there are no laboratory abnormalities specifically associated with this condition. Treatment of fibromyalgia requires a holistic approach. Regular exercise like cardiovascular fitness training, which includes fast walking, biking, swimming, or water aerobics, can help by reducing pain and fatigue. Relaxation techniques and good sleep hygiene can also help. If these approaches don't work, antidepressants like amitriptyline and serotonin norepinephrine reuptake inhibitors can help by elevating serotonin and norepinephrine levels. Finally, neuropathic pain agents like pregabalin and gabapentin, which slow nerve impulses by inhibiting high-voltage activated calcium channels, can help control pain. They can also help with sleep problems since one of their side effects is sedation. Ataxia is another side effect that can occur, and it represents a lack of voluntary coordination of muscle movements. Alright, as a quick recap, polymyositis is an inflammatory disorder of the muscles caused mainly by CD8 positive T cells destroying muscle tissue. Symptoms of polymyositis include bilateral weakness and muscle wasting affecting proximal muscle groups like the shoulder or hips. Gower's sign, muscle pain, dysphagia, interstitial lung disease, and myocarditis can also be present. Dermatomyositis is an inflammatory disorder of the muscles and the skin, mediated mainly by complement activation and autoantibodies like ANA, anti-MI2, and anti-Jo1 that result in bilateral proximal muscle weakness and photosensitive skin rashes. People with this disorder are at an increased risk of developing hidden malignancies. Polymyalgia rheumatica is an inflammatory disorder that affects the joints and not the muscles. The myalgia is due to referred pain. The most commonly affected joints are the shoulders and hips, and it's associated with temporal arteritis. Finally, fibromyalgia is a chronic condition that causes widespread muscle pain, excessive tenderness in many areas of the body, sleep, cognitive and mood abnormalities. The main cause is suspected to be increased sensitivity to pain, so similar to polymyalgia rheumatica, there's no muscle damage, so creatine kinase will not be elevated. Now, back to our cases. First, Yuyan presented with symptoms suggestive of polymyalgia rheumatica. These include a history of fatigue, weight loss, fevers, inflamed joints, and bilateral pain, as well as stiffness in the shoulder and hip girdles. Symptom duration and complications are also characteristics of polymyalgia. They are worse at night, last for more than an hour, and cause difficulties getting out of bed in the morning. The lack of muscle weakness makes myositis unlikely. The diagnosis was indirectly confirmed by a blood test, which showed increased inflammatory markers and normal creatine kinase levels. X-rays of the affected joints are also needed to exclude other causes of joint disease. Elizabeth, on the other hand, came in with a 4-year history of chronic, widespread body pain, fatigue, and sleep problems. Examination revealed many tender points throughout her body, but no sign of joint swelling or weakness. Considering her clinical picture, the fact that her symptoms lasted more than 3 months and that blood tests were normal, we can diagnose Elizabeth with fibromyalgia. Other tests might be needed to exclude other possible causes of muscle pain.
A 13-year-old boy named Lucas comes to the clinic complaining of right knee pain, which gets worse when he is running, jumping, or climbing stairs. Upon further questioning, Lucas mentions that he plays basketball for his school team, and recently, he started training more intensely for an upcoming tournament. On physical examination, you are able to move his hip in all directions with no resistance or pain. But you notice that his right knee has a more prominent tibial tubercle, which is also tender to the touch. Some days later, a 4-year-old girl named Sophia is brought to the clinic by her mother. Earlier that day, Sophia's older brother was swinging her by the arms. Since then, Sophia has been experiencing pain in her right arm when she tries to move it. On physical examination, you notice that Sophia is holding her arm by her body and cries when you try to move it. You decide to quickly hyperpronate her arm, after which Sophia becomes able to use her arm again without pain. Okay, both Lucas and Sophia seem to have some form of pediatric musculoskeletal condition, meaning a condition that commonly affects the muscles, bones, or cartilage of individuals younger than 18 years. For your tests, the most high-yield pediatric musculoskeletal disorders include developmental dysplasia of the hip, Legg-Calvé-Perthes disease, slipped capital femoral epiphysis, Osgood-Schlatter disease, patellofemoral syndrome, radial head subluxation, and a variety of bone fractures. Okay, let's start with developmental dysplasia of the hip, or DDH, which is also known as congenital hip dysplasia. In DDH, the femoral head dislocates out of the acetabulum during development in utero. For your exams, it's important to keep in mind that this is more common in twin or multiple pregnancies, where the fetuses have to share the space within the uterus, which may put a lot of pressure on them, as well as in firstborns, because the mother's uterus is not as stretched out, or when the fetus is lying in a breech position within the mother's uterus, with its buttock near the cervix at the time of delivery. Another situation that can lead to DDH is oligohydramnios, when there's not enough amniotic fluid to expand the uterine cavity so that the fetus can have enough room. In any case, over time, as the femoral head spends a lot of time outside of the acetabulum, the acetabular ligaments and fatty tissue start expanding to fill the space that would normally be occupied by the femoral head. At the same time, remember that during development, the femoral head functions as a template around which the acetabulum is formed. So without it, in DDH, the acetabulum turns out shallow, making it a poor fit for the femoral head. Another thing to note is that this misalignment of the hip may eventually wear down the articular cartilage, leading to the development of osteoarthritis in early adulthood. Symptoms of developmental dysplasia of the hip may vary according to age. In a test question, look for a newborn or infant with legs of unequal length, or asymmetric skin folds around the groin. On the other hand, older kids may present with painless limping or hip pain that can radiate to the knee. Diagnosis of developmental dysplasia of the hip starts with physical examination. For your exams, you must remember 2 maneuvers. In the Barlow maneuver, the hip is abducted while holding the knee straight, which in the case of hip dysplasia would cause the femoral head to pop out of the socket. On the other hand, in the Ortolani maneuver, the baby's hip is flexed at 90 degrees and then gently abducted. If the femoral head is out of the socket, the Ortolani maneuver will cause it to slip back into the acetabulum, which would feel and sound like a clunk. In addition, imaging techniques like ultrasound can be used in children younger than 4 months of age, so as to assess the position of the femoral head and the structure of the acetabulum. On the other hand, X-rays are recommended for children older than 4 months, as the hip cartilage begins to ossify and become easily visible on X-ray. Now, the treatment of congenital hip dysplasia depends on the age of the child and extent of the deformity. Before 6 months of age, abduction splints can be used for a period of 1 to 2 months, such as the Pavlik harness, that holds the hip joint flexed and abducted. This helps to keep the femoral head within the socket to promote normal hip joint development. For those older than 6 months, closed manual reduction of the femoral head into the acetabulum can be performed under anesthesia. If this doesn't work, open surgical reduction might be necessary. All right, moving on to Legg-Calvé-Perthes disease. This is a hip disorder that occurs when the blood supply to the head of the femur gets disrupted. Normally, the head of the femur is supplied by 3 main arterial branches, which are the medial and lateral circumflex arteries and the artery of ligamentum teres. In Legg-Calvé-Perthes disease, the blood supply to the femur is disrupted, and this causes the bone to stop growing and die off, a process called avascular necrosis. The reason why this happens is not exactly known, which is why it's also called idiopathic avascular necrosis of the femoral head. However, the main risk factor to keep in mind is repeated minor trauma to the hip joint, which might be associated with a child's hyperactivity. In any case, over time, the femoral head becomes more fragile and prone to fractures. Over time, the weakened bone may lose its normal round shape and become flattened, so it can no longer smoothly rotate inside the acetabulum. Symptoms of Legg-Calvé-Perthes disease most commonly present in males between the age of 3 and 12 years and include a gradual onset limp with or without hip pain that typically gets worse with activity. One high-yield fact to remember for your tests is that the hip pain in Legg-Calvé-Perthes disease can sometimes refer to the knee, so these kids might initially complain of knee pain. On physical examination, remember that it's common to find a limited range of motion, which is particularly evident for abduction, as well as internal rotation of the hip. Diagnosis of Legg-Calvé-Perthes disease is based on imaging studies like X-ray of the hip, which can show fragmentation or flattening of the femoral head. However, for your tests, keep in mind that early on in the disease, X-ray can be normal. And in this case, MRI can be useful to confirm the diagnosis. Treatment of Legg-Calvé-Perthes disease is typically conservative and may include reduced weight bearing on the affected side, physical therapy, and pain management. In severe cases with extensive damage to the femoral head, surgery might be recommended. Next up is slipped capital femoral epiphysis, or SCFE for short. Now, long bones, such as the femur, have a diaphysis, or bone shaft, a metaphysis, or neck portion on each side, and an epiphysis at each end. And remember that the proximal one is the femoral head. Between each metaphysis and epiphysis, there's the physis, or growth plate, which is a cartilaginous structure that enables growth. Normally, as an individual is growing, the growth plate is relatively weak and vulnerable to shearing forces. Eventually, around the age of 16 in females and 19 in males, the growth plate ossifies and fuses with the epiphysis. In SCFE, increased stress on the growth plate causes it to break, and this leads the femoral head to slip away from the neck, just like a scoop of ice cream slipping off a cone. Now, keep in mind that the femoral head remains well held in the acetabulum by the joint capsule and the ligamentum teres femoris, so it's just the femoral neck that gets displaced anterolaterally and superiorly. And this is actually high yield. Now, the exact cause of SCFE is unknown, but what's important to remember for your tests is that it is often associated with obesity. That's because the increased weight is thought to increase the mechanical force on the growth plate, causing it to break. In addition, hormonal changes that normally occur during adolescence or with endocrine disorders like hypothyroidism can make the growth plate weaker. Symptoms of slipped capital femoral epiphysis typically present between the ages of 10 and 16 years and include hip pain that becomes worse with activity and may sometimes refer to the thigh or knee. This can also result in limping. On physical examination, remember that these individuals often also have reduced range of motion, especially with hip movements that involve abduction and internal rotation. Diagnosis of slipped capital femoral epiphysis includes imaging studies like a hip X-ray. To better visualize both hip joints, the X-ray should be obtained in both an anterior view as well as a lateral view, with the individual sitting in a frog-like position. Some characteristic X-ray findings of SCFE include widening of the growth plate, as well as anterolateral and superior displacement of the femoral neck relative to the head. Treatment of SCFE generally involves decreasing weight bearing on the affected side, in addition to surgery to realign the femoral head and neck using a screw. Moving on to Osgood-Schlatter disease. This refers to inflammation of the tibial tubercle, which is a small bony prominence at the proximal tibia. What's important to know is that the tibial tubercle serves as an apophysis, or attachment site, for the patellar ligament, which arises from the patella. In this way, contraction of the quadriceps muscles can pull the patella and tibial tubercle, causing extension of the knee joint. And this allows you to walk, climb stairs, run, and jump. And what you need to remember for your exams is that at birth, the tibial tubercle consists of cartilage, but between the ages of 9 and 15, it begins to ossify, and at around the age of 18, becomes a bony tuberosity. And that's a high-yield fact. The cause of Osgood-Schlatter disease is not exactly understood, but it's thought that intense physical activity that involves repeated sprinting and jumping, like when playing basketball and volleyball, can expose the tibial tubercle to constant strain and traction. This results in inflammation, partial avulsion or tearing, and fragmentation of the tibial tubercle, which is called traction apophysitis. When this happens over a long period of time, the chronic inflammation is followed by a healing process, which occurs by laying down new bone at the tibial tubercle, causing it to be more prominent. Symptoms of Osgood-Schlatter disease typically present between the age of 9 and 14 years, after the growth spurt, and include progressive anterior knee pain. For your exams, what's important to remember is that this pain gets worse when going up or down stairs, as well as with physical activities like running, jumping, and squatting. On physical examination, what you'll often see is swelling or a prominent enlargement of the tibial tubercle. Now, for the diagnosis of Osgood-Schlatter disease, an ultrasound may reveal soft tissue swelling around the tibial tubercle. In severe cases, an X-ray might also show fragmentation of the tibial tuberosity. For treatment of Osgood-Schlatter disease, all that's typically needed is pain medication, reducing physical activity, and applying ice to the tuberosity to reduce the swelling. That's because the disease is usually self-resolving once the individual stops growing. For severe cases, though, such as when fragmented bones break off and get trapped within the patella ligament, surgery might be necessary. Next is patellofemoral syndrome, which affects the patellofemoral joint. Normally, this joint is formed by the patella that sits onto the trochlear groove on the distal part of the femur and is covered by a slippery articular cartilage that allows for smooth movement when flexing or extending the knee. In patellofemoral syndrome, there's inflammation and wearing off of the articular cartilage, which might be followed by injury to the bone. This results from mechanical stress between the patella and the trochlear groove, which is often linked to overuse of the patellofemoral joint, which is common in runners. That's why patellofemoral syndrome is also called runner's knee. And this is a high-yield fact. And for your exams, remember that patellofemoral syndrome affects females more than males. So in a test question, look for a female athlete. Another less frequent cause of patellofemoral syndrome is malalignment of the patella with the trochlear groove, which could be due to knee trauma or weakness of the quadriceps muscles, and results in uneven distribution of the mechanical load. Symptoms of patellofemoral syndrome typically begin during adolescence and include anterior knee pain that's often described as being around or behind the patella. The pain typically gets worse with knee flexion, as in running, squatting, climbing stairs, and prolonged sitting. On physical exam, one high-yield test to remember is the patellofemoral compression test, in which pressing on the patella into the trochlear groove reproduces the pain. Now, the diagnosis of patellofemoral syndrome is mainly based on history and physical examination. However, X-ray of the knee can sometimes be done to rule out other causes of knee pain, such as osteoarthritis and fractures. Treatment of patellofemoral syndrome is mainly conservative, which involves rest from physical activities like running, and pain management by using anti-inflammatory medications, like NSAIDs. Physical therapy might also help to strengthen the quadriceps muscles, which help stabilize the patellofemoral joint. All right, another pediatric musculoskeletal disorder that you need to know for your tests is radial head subluxation. Normally, the head of the radius is attached to the radial notch on the ulna by the annular ligament. This allows the joint to remain stable and rotate during supination, or when the forearm is turned outward, as well as during pronation, which is when the forearm is turned inward. Radial head subluxation typically occurs in children younger than 5 years, when the annular ligament has not fully developed yet. In a test question, look for a case of a sudden, forceful pull on the child's forearm. This causes the head of the radius to partially slip away from the annular ligament. A part of the annular ligament could also slip into the radiohumeral joint, where it gets trapped between the radius and the humerus. This prevents the radial head from spontaneously relocating into its normal place. Symptoms of radial head subluxation typically include an inability to move the affected limb due to elbow pain that aggravates with movement. What's especially high yield is that the child will typically hold the affected forearm in a pronated and extended or slightly flexed position. Diagnosis of radial head subluxation is mainly based on history and physical examination. Imaging studies like X-ray can be done to rule out other causes of elbow pain like fractures. Treatment of radial head subluxation aims at returning the radial head into its normal place. To do this, you should remember 2 maneuvers. The first one involves supination of the forearm, while the elbow is slightly flexed. And the other one involves hyperpronation of the forearm, which is more effective and less painful. Okay, moving on to pediatric bone fractures. What's important to remember is that pediatric bones are not merely smaller versions of adult bones. In fact, they have unique characteristics, such as a thicker and stronger periosteum. Now, pediatric fractures can be classified as complete, where high-energy forces cause the bone to break from side to side, or incomplete, where the bone doesn't break completely, and usually only one side of the bone is involved. For your exams, keep in mind that incomplete fractures are particularly common in children due to the presence of the stronger periosteum, which can better resist forces applied to bones. Treatment of bone fractures generally involves immobilization of the affected limb, in addition to the use of removable splints or casts to allow the bone to heal. Some severe or displaced fractures may require surgery. Now, the 4 high-yield types of pediatric fractures include torus fractures, bowing fractures, greenstick fractures, and physiofractures. All right, let's start with torus, or buckle fracture, which usually occurs following a fall on outstretched hands, also known as fouche injury. For your exams, remember that this type of fracture commonly affects the metaphysis of long bones, because it's where the bone is most porous and thus the weakest. Torus fractures typically occur following an axial or longitudinal force that compresses one side of the bone, called the compression or concave side. This leads the bone's periosteum and cortex on that side to buckle and produce a bulge, hence the name torus, which is a Latin word that means a bulge or protuberance. In contrast, the other side of the bone, called the tension or convex side, remains intact. For diagnosis, on an X-ray, a torus fracture can often be seen as a small bulge on one side of the bone. Next, there's the greenstick fracture, which typically occurs due to a bending force that creates more stress on the convex side of the bone, called the tension side, than the concave side, called the compression side. So, in contrast with torus fractures, with green stick fractures, the force can cause the cortex and periosteum on the tension side to break, while the compression side will remain intact, just like when you try to break a green stick or twig. Diagnosis of green stick fracture can be confirmed with an X-ray, which would clearly show an incomplete fracture, with a breach on one side of the bone, while the other side should be intact. Finally, we have bowing fracture, also known as plastic deformity. This occurs when the bone shaft is exposed to a longitudinal force that exceeds the bone's ability to return to its normal shape, but is not strong enough to break it. This causes the bone to bend and assume a more curved or bowed shape. So for your exams, remember that this is actually a shape deformity and not a true fracture. However, it's often associated with microscopic fractures in the periosteum of the bone. To diagnose a bowing fracture, an X-ray would show bowing, or increased curvature of the bone. Now, fractures can also affect the growth plate, known as the physis. The main problem is that physial fractures can impair bone growth and lengthening. If the whole growth plate is involved, there's usually complete growth arrest, which can lead to asymmetrical growth of the limbs. On the other hand, if only a portion of the growth plate is affected, there's partial growth arrest. This results in angular deformity with uneven bone growth, where one side of the bone grows more than the other. Because of that, follow-up with X-rays is recommended for several years to make sure that the bone is growing properly. All right, as a quick recap, pediatric musculoskeletal disorders include developmental dysplasia of the hip, which can occur when the femoral head dislocates out of its acetabulum in utero. This is more common with multiple pregnancies, firstborns, and breech presentation, and presents with leg length discrepancy, asymmetric groin folds, painless limping, or hip pain. Legg-Calvé-Perthes disease occurs when the blood supply to the head of the femur gets disrupted, leading to avascular necrosis. This can occur due to repeated minor trauma and presents with hip pain that may refer to the knee, as well as limited hip abduction and internal rotation. Next is slipped capital femoral epiphysis, where the femoral head and neck slip away from each other. This most commonly occurs in obese adolescents and causes hip pain that can refer to the thigh or knee, limping, and limited hip abduction and internal rotation. Osgood-Schlatter disease, or traction apophysitis, refers to inflammation and fragmentation of the tibial tubercle, which often occurs with sports that include running and jumping, and causes anterior knee pain and tubercle enlargement. Patellofemoral syndrome results from inflammation and wearing off of the articular cartilages of the patellofemoral joint. This is associated with malalignment of the patella with the trochlear groove, or overuse of the joint, as in running, and presents with anterior knee pain that gets worse with knee flexion. Radial head subluxation occurs when the radial head slips away from the annular ligament that holds it to the ulna, which could result from a fall or pull on the child's forearms when it's pronated and extended, and causes the child to hold the affected forearm pronated and extended or slightly flexed. Finally, pediatric fractures include torus or buccal fractures due to an axial or longitudinal force that breaks the compression site, green stick fractures due to a bending force that breaks the tension, bowing fractures, also known as plastic deformity, due to a longitudinal force to the bone shaft that causes the bone to bend, and growth plate or physial fractures, which can impair bone growth and lengthening, resulting in asymmetrical growth of the limbs and angular deformity. Okay, back to our cases. Lucas is a 13-year-old boy who presents with right knee pain that gets worse with running and jumping. This should make you think of a musculoskeletal disorder of the knee itself, or a disorder that affects the hip joint, where the pain could refer to the knee. The fact that Lucas's hip joint shows full range of motion and no pain should help you exclude hip joint pathologies. Now, a big clue is his intense basketball training, which is a risk factor for traction apophysitis. And the key here is the presence of a prominent and tender tibial tubercle, which indicates that Lucas has Osgood-Schlatter disease. On the other hand, Sophia is a 4-year-old girl who presents with right arm pain after her brother was swinging her by the arms. This, combined with the fact that Sophia holds her arm extended and pronated by her body, and that her arm pain was relieved after hyperpronation, makes this a straightforward case of radial head subluxation.
Jody is a 55-year-old woman who presents with a 6-month history of bilateral hand and wrist stiffness. She mentions that the stiffness lasts for more than an hour a day but tends to improve as she uses the affected joints. Examination shows swelling, limited range of movement, and subcutaneous nodules over the proximal interphalangeal joints, but no redness. Then you see Carrie, a 60-year-old woman who comes in with a 1-year history of pain in the right knee that has gotten progressively worse. The pain is worse in the evening or with use of the affected limb and is associated with stiffness, which typically occurs at rest and lasts around 10 to 15 minutes. Examination reveals Carrie is obese, has bowing of the right knee, and that the affected joint has a limited range of motion. Blood tests are ordered in both cases, showing in Jody's case high levels of rheumatoid factor, RF, and anti-citrulline peptide antibody, ACPA, whereas in Carrie's case, both antibodies were absent. Both people have arthritis. Now, a healthy joint usually consists of 2 bones, each with its own layer of articular cartilage. Articular cartilage is a type of connective tissue with a lubricated surface that acts like a protective cushion for bones to smoothly glide against. Now, there are many types of joints, including fibrous, cartilaginous, and synovial joints, which have additional components depending on their function. For example, synovial joints, like those of the wrist, elbow, knees, shoulders, and hips, are mobile joints that connect 2 bones via a fibrous capsule that's continuous with the periosteum, which is the outer layer of bones. The fibrous capsule is lined with a synovial membrane that has cells that remove debris and produce synovial fluid, which is a viscous fluid found inside the joint capsule to lubricate the joint. Together, the synovial membrane and articular cartilage form the inner lining of the joint space. Now, arthritis refers to a group of diseases that cause destruction of one or more joints and can be classified as inflammatory or non-inflammatory. Inflammatory arthritis is caused by an immune response attacking the joints. It includes conditions with unknown cause like rheumatoid arthritis and juvenile idiopathic arthritis, or it can be secondary to diseases like systemic lupus erythematosus and Sjogren's syndrome. On the other hand, non-inflammatory arthritis is caused by mechanical wear and tear, and it's mostly represented by osteoarthritis. Generally, in terms of symptoms, there are a few differences between inflammatory and non-inflammatory arthritis. Okay, so inflammatory conditions are usually accompanied by joint swelling, erythema, prolonged morning stiffness lasting more than 1 hour, and symmetric pain that improves with use. Most of these conditions are also associated with extra-articular symptoms like fever and fatigue. On the other hand, non-inflammatory arthritis is usually suggested by asymmetric pain that gets worse with use and affects weight-bearing joints like the knee and the hip, and morning stiffness that lasts less than 1 hour. Extra-articular symptoms are usually absent in non-inflammatory arthritis. Let's begin with the most common type of inflammatory arthritis. Rheumatoid arthritis is a chronic, progressive, and inflammatory disorder that affects synovial joints and sometimes other parts of the body, like the skin and the lungs. It's thought to be an autoimmune reaction, however, the exact cause is unknown. Generally speaking, it seems to be associated with environmental risk factors, like infections and smoking, and with a genetic predisposition, like in biologically female individuals, and having the alleles HLA-DR1 and HLA-DR4. So basically, it's believed that environmental risk factors in those with genetic predispositions end up modifying normal articular proteins in synovial joints. As a consequence, the modified proteins end up confusing the cells of our immune system, which fail to recognize them as being self, or part of the normal human body. So at this point, the protein is now a self-antigen. Antigen-presenting cells then pick up the self-antigen and take them to the lymph nodes where they activate CD4-positive T helper cells. T helper cells then stimulate the nearby B cells to proliferate and differentiate into plasma cells, which produce specific autoantibodies against these self-antigens, namely rheumatoid factor, or RF, and anticyclic citrullinated peptide antibody, or anti-CCP. Soon after, both T helper cells and antibodies enter the circulation and reach the joints. Once there, T cells secrete cytokines to recruit more inflammatory cells, like macrophages, into the joint space. Macrophages will also produce inflammatory cytokines like tumor necrosis factor, or TNF-alpha, interleukin-1, or IL-1, and interleukin-6, or IL-6, which together with the cytokines released by T cells, stimulate synovial cells to proliferate. This increase in synovial cells and immune cells in the joint creates a pannus, which is a thick, swollen synovial membrane with granulation or scar tissue made up of fibroblasts, myofibroblasts, and inflammatory cells. Over time, the cytokines released in the pannus start to break down the articular cartilage, so the underlying bones are exposed and can directly rub against one another, leading to bone erosion. Meanwhile, the antibodies that enter the joint space bind to their targets and form immune complexes that accumulate in the synovial fluid, activating the complement system, which further contributes to joint inflammation and injury. Now, when it comes to articular symptoms, rheumatoid arthritis typically involves 3 or more joints symmetrically, meaning the same joint groups on both sides of the body, like the finger joints in both hands, for instance. The hallmark symptom of rheumatoid arthritis is chronic morning stiffness that lasts for over an hour, improves with use, and has lasted for more than 6 weeks. The most frequent sites are the proximal interphalangeal joints of the hand, the metacarpophalangeal joints of the hand, and the wrists. By contrast, the first carpometacarpal joint and the distal interphalangeal joints are rarely involved because they contain very little synovium. Associated symptoms include reduced grip strength and range of motion, pain, and swelling. As a particularity, swelling in rheumatoid arthritis is different from the one in osteoarthritis. In rheumatoid arthritis, the swelling is caused by soft tissue edema secondary to inflammation, whereas in osteoarthritis, swelling is secondary to bony overgrowth that makes the joint look larger. Another distinction to help you out is that rheumatoid arthritis doesn't usually cause redness or warmth because the inflammatory process is so gradual and chronic. However, sometimes it can present with acute inflammatory signs such as edema, redness, warmth, and pain when there's an acute episode of rheumatoid arthritis, also called a flare. Now, other joints of the body besides the hands can be affected. For example, in the feet, it's usually the metatarsophalangeal joints, causing the individual to bear more weight on the heels and hyperextend their toes. Hip involvement usually happens later in the disease, causing pain in the groin, thigh, or lower back. One very dangerous spot is the C1-C2 joint, or the atlantoaxial joint, which is the only synovial joint in the spine. When it's affected, it can cause neck pain, and sometimes extension of the neck during endotracheal intubation can worsen the subluxation, leading to acute compression of the spinal cord or vertebral arteries. This can lead to spinal cord compression and tetraplegia, which is paralysis of all 4 limbs and torso. As the disease progresses, there are also a series of deformities that can occur due to joint destruction. One of them is swan neck deformity, which doesn't occur in the neck but in the fingers, causing them to deform and resemble the shape of a swan's neck. Specifically, the distal interphalangeal joint of the affected finger is in flexion, or bent, while the proximal interphalangeal joint is in hyperextension, or bent beyond its normal range of motion. There's also the boutonniere deformity, where roles reverse, meaning the proximal interphalangeal joint flexes to face the palm, and the distal interphalangeal joint is in hyperextension, facing away from the palm. Sometimes, when the metacarpophalangeal joints are severely affected, an ulnar drift can occur, where the fingers lean away from the thumb and toward the pinky. This is due to the weakened radiocarpal ligaments that cause radial rotation of the metacarpals and carpus on the radius, which results in ulnar deviation of the joint. Another important deformity is the Z deformity, where the thumb flexes at the metacarpophalangeal joint and hyperextends at the interphalangeal joint. This makes the finger look as if the individual is trying to hitch a ride, which is why it's also called the hitchhiker thumb deformity. Now, if the spine is involved, cervical joint destruction can lead to vertebral misalignment or subluxation, causing pain, neurologic deficits, and deformity. Finally, there can also be toe deformities, like the claw-toe deformity, where the metatarsophalangeal joint is hyperextended, while the proximal and distal interphalangeal joints are flexed. This makes affected toes look like bird claws. Unfortunately, the cytokines released by the immune system don't stay in just one place. Instead, they can reach multiple organ systems, causing extra-articular symptoms. For example, interleukin 1 and 6 travel to the brain, where they act as pyrogens, inducing fever, fatigue, loss of appetite, and ultimately weight loss. They can also lead to inflammation of the uvea, which is the layer of tissue beneath the white of the eye or sclera, causing uveitis. Some signs of uveitis include eye pain, conjunctival redness, blurry vision, miosis, and rarely with hypopyon, or accumulation of pus in the anterior chamber of the eye. If the sclera is involved, it can cause scleritis. Now, in the skin, as well as in many visceral organs, the inflammatory cytokines lead to the formation of rheumatoid nodules, which are bumps with a central area of fibrinoid necrosis that's surrounded by palisading histiocytes, a type of macrophage. Palisading means the cells are arranged in layers around the necrotic area, parallel with each other, almost like a picket fence. On examination, these are seen as singular or multiple subcutaneous nodules that are firm to the touch, non-painful, and distributed around the affected joint. In the soft tissue, the disease can lead to carpal tunnel syndrome. The carpal tunnel is a narrow passageway formed by the carpal bones and the transverse carpal ligament at the wrist, which gives passage to the median nerve and muscle tendons. Because rheumatoid arthritis causes tendon inflammation, these swell up and compress the median nerve, causing carpal tunnel syndrome and symptoms such as paresthesia or tingling sensation, pain, and numbness of the hand. Blood vessels can also be affected, causing wall inflammation resulting in various forms of vasculitis, which can make blood vessels more prone to developing atheromatous or fibrofatty plaques. These can lead to cardiovascular disease like myocardial infarction and stroke. In fact, cardiovascular disease is the primary cause of mortality associated with rheumatoid arthritis. Meanwhile, within the lung interstitium, fibroblasts get activated and proliferate, causing pulmonary fibrosis that impairs the alveolar gas exchange. The pleural cavities surrounding the lungs can get inflamed as well, causing them to fill up with fluid, which is known as pleural effusion, and it can impair lung expansion too, interfering even more with gas exchange. Additionally, there's Kaplan syndrome, which is when the individual has both pneumoconiosis and rheumatoid arthritis, and this tends to manifest as intrapulmonary nodules. The liver can start producing high amounts of hepcidin in response to inflammatory cytokines. Hepcidin decreases serum iron levels by inhibiting its absorption by the gut and trapping it into macrophages or liver cells, leading to anemia of chronic disease. In the spleen, rheumatoid arthritis can lead to splenomegaly and neutropenia, a combination called Felty syndrome. It can also be associated with Sjogren's syndrome, which is an autoimmune disease that primarily attacks the lacrimal and salivary glands, impairing their ability to secrete fluids and resulting in dry eyes, mouth, and skin, among many other symptoms. And finally, rheumatoid arthritis can lead to AA amyloidosis, which is a type of amyloidosis that occurs as a reaction to another illness. In short, rheumatoid arthritis causes the liver to produce a protein called SAA, or serum amyloid A protein, in high levels, which is a normal reaction. However, if inflammation persists, a small portion of the SAA protein, called AA protein, will separate from SAA and deposit in organs as AA amyloid, especially in the kidneys, where it causes organ damage. Diagnosis of rheumatoid arthritis is based on a complete clinical evaluation, followed by a series of tests, since some conditions, like parvovirus B19 infection, may mimic the symptoms of rheumatoid arthritis. Okay, so when it comes to blood tests, there might be signs of anemia, thrombocytosis, mild leukocytosis, an elevated erythrocyte sedimentation rate, or ESR, and C-reactive protein, or CRP, all of which are caused by the chronic inflammation associated with the disease. It's also important to test for autoantibodies like RF and anti-CCP. For your exam, you should remember that rheumatoid factor is an IgM antibody that targets the constant Fc component of human IgG antibodies. Anticyclic citrullinated peptide antibody is an antibody that targets citrullinated proteins, which are proteins whose arginine residues have been chemically modified to citrulline through a process called citrullination. A high-yield fact you should know is that although RF is associated with rheumatoid arthritis, it's not highly specific as it's positive in just 70% of cases. In addition, RF can also be elevated in other diseases like Sjogren's syndrome, lupus, sarcoidosis, and hepatitis B, among many others. On the other hand, anti-CCP is more specific of rheumatoid arthritis, as it has a specificity of almost 96%. This means that there are cases of rheumatoid arthritis with negative serology. In these cases, diagnosis is based solely on clinical findings and imaging. A minority of individuals could also present anti-nuclear antibodies, or ANA, which are formed against the normal proteins of a cell's nucleus. Radiographs of the affected joint are also important for diagnosis. Over time, some possible changes might include juxtaarticular osteopenia or decreased bone density around affected joints that shows as areas with increased transparency on an X-ray, soft tissue swelling, which is seen as a thick halo around the bone, narrowing of the joint space, bone erosions, which look like someone bit into the bone, and rarely subchondral cysts, which are sacs of hyaluronic acid that form in the subchondral bone, the layer of bone just under the cartilage. On an X-ray, subchondral cysts look like dark, round, and fairly well-delimited areas inside the bone. In some cases, arthrocentesis can be done, where synovial fluid is collected from an affected joint and examined under a microscope and sent for gram stain and cultures, especially during a flare, to make sure there's no evidence of crystals, like in gout or pseudogout, or signs of infection, like in septic arthritis. There's no cure for rheumatoid arthritis, but there are ways to keep the disease under control. The main treatment consists of long-term medications called disease-modifying anti-rheumatic drugs, or DMARDs, which can be non-biological or biological. Most individuals with an acute rheumatoid arthritis flare are started on non-biological DMARDs like methotrexate, leflunomide, hydroxychloroquine, and sulfasalazine. The most common monotherapy is methotrexate, which is a folic acid analog that inhibits dihydrofolate reductase, an enzyme that participates in tetrahydrofolate synthesis, which in return inhibits the synthesis of DNA, RNA, and proteins. However, in rheumatoid arthritis, this doesn't seem to be the main mechanism by which methotrexate works. Instead, there seems to be multiple other mechanisms involved, including immune system inhibition. Some notable side effects include pulmonary fibrosis, hepatotoxicity, stomatitis or painful mouth ulcers, and nephrotoxicity. Now, methotrexate can also lead to folate deficiency, which can cause megaloblastic anemia, a macrocytic type of anemia that results from inhibition of DNA synthesis during red blood cell production. Another common side effect is myelosuppression, which is reversible with leucovorin rescue. This is because leucovorin, also called folinic acid, has vitamin activity equivalent to that of folic acid, but doesn't require dihydrofolate reductase to be metabolized. And finally, methotrexate is teratogenic, causing neural tube defects via folic acid deficiency, which means it should not be used by pregnant women. When methotrexate monotherapy doesn't work or it's contraindicated, the person should take another DMARD. There's leflunomide, which reversibly inhibits dihydroorotate dehydrogenase, preventing pyrimidine synthesis, which suppresses T-cell proliferation. Some side effects include diarrhea, hypertension, hepatotoxicity, and teratogenicity. Then there's hydroxychloroquine, which is generally considered to be the safest DMARD and a go-to drug for pregnancy. It works by inhibiting the cells of the immune system through multiple mechanisms, such as increasing lysosomal pH in antigen-presenting cells and blocking toll-like receptors on plasmacytoid dendritic cells. Toll-like receptors are surface proteins that have a role in recognizing the pathogens that enter our bodies. The most important side effects are eye toxicity, hepatotoxicity, excessive coloring of the skin, nausea, and diarrhea. And finally, sulfasalazine is a combination of sulfapyridine, an antibiotic, and 5-aminosalicylic acid, an anti-inflammatory drug, and it's activated by colonic bacteria. Side effects include malaise, nausea, sulfonamide toxicity, and reversible oligospermia. In case of severe disease resistant to combination therapy, individuals should be started on biological DMARDs, also called biologics, which suppress some part of the immune system. For example, abatacept suppresses T cells, rituximab suppresses B cells, while others block specific cytokines. One of the medications that block cytokine activity is etanercept. It reduces TNF-alpha activity by acting as a decoy receptor, preventing the cytokine from attaching to its receptors on healthy tissues. There's also infliximab and adalimumab, two anti-TNF-alpha monoclonal antibodies against the cytokine. Now, a major downside of these drugs that you might come across in your test is the fact that they increase predisposition to infection, including reactivation of latent tuberculosis, since TNF is important in granuloma formation and stabilization. Hence, keep in mind that you always have to test for latent TB before starting TNF-alpha inhibitors. They can also lead to drug-induced lupus. Now, to help you differentiate between the two, pharmaceutical companies use the sept suffix to indicate the medication is a protein receptor and the mab suffix to indicate it's a monoclonal antibody. In addition, something that's frequently tested is that there are also short-term medications used to provide analgesia and symptom relief. These consist of non-steroidal anti-inflammatory drugs, or NSAIDs, like naproxen, or glucocorticoids like prednisone, which are used especially during flares because they're fast-acting and provide quicker symptom relief when compared to DMARDs. NSAIDs are preferred over glucocorticoids because they have fewer side effects. Next, there's a family of inflammatory arthritides called juvenile idiopathic arthritis that occur in young individuals under the age of 16. The cause is unknown, hence the name idiopathic, but it can be associated with the gene HLA-B21 and with triggers such as infections. It's also thought to have an autoimmune basis, which leads to the recruitment and activation of inflammatory cells that release pro-inflammatory cytokines. These cytokines reach different parts of the body and cause inflammation and tissue injury, leading to the main symptoms of juvenile idiopathic arthritis. Typically, there's symmetrical involvement of larger joints, like the knee or the ankle. These individuals usually present with the typical inflammatory joint signs, which are worse in the morning or with rest. The most common type is called oligoarticular arthritis, in which there are up to 4 joints affected. Then there's polyarticular arthritis, which affects 5 or more joints. These two types can also be associated with uveitis, and if tendons are involved, enthesitis might develop. Finally, there's another type called systemic juvenile idiopathic arthritis, which is rather frequently tested on exams. It affects not only the joints, but the whole body. The skin can be affected too, mainly showing a salmon pink macular rash that often appears with fever. Other systemic abnormalities that can occur include daily spiking fever, splenomegaly, generalized adenopathy, and pericarditis or pleuritis. Something else worth noting is that joint involvement can actually occur weeks or months after systemic symptoms, making diagnosis difficult. Diagnosis is mostly clinical, but it can also include blood tests, where typical findings include leukocytosis, thrombocytosis, anemia, and increased levels of ESR and CRP, while RF, ANA, and anti-CCP can be positive or negative. Genetic testing might be positive for HLA-B21. Treatment involves intra-articular corticosteroid injections, NSAIDs, and DMARDs, particularly methotrexate and biologic agents. If methotrexate is not effective, TNF inhibitors are used. Alright, let's move on to non-inflammatory arthritis, which usually refers to osteoarthritis. In fact, it's the most common type of arthritis overall. Okay, so osteoarthritis is a chronic condition characterized by the breakdown of joint cartilage and underlying bone, followed by inadequate repair. Now, unlike rheumatoid arthritis, which is an autoimmune disorder, osteoarthritis is considered a mechanical degenerative joint disorder. This is because the main culprit seems to be the daily stress applied to joints in our lifetime, especially to weight-bearing joints like those of the ankle, knee, and hip. This is why the biggest risk factor for osteoarthritis is age, alongside joint injury, obesity, and altered walking patterns, which can increase joint stress. Now, although osteoarthritis is traditionally considered a non-inflammatory disease, recent data suggests that inflammation seems to be involved in osteoarthritis as well, especially pro-inflammatory cytokines like interleukin-1, interleukin-6, and tumor necrosis factor alpha that can break down cartilage through proteolysis or by blocking the formation of new cartilage. Now, regardless of the initial cause of damage, chondrocytes in the joint can repair the cartilage by producing cartilaginous matrix made up of glycosaminoglycans, proteoglycans, collagen fibers, and sometimes elastin. In early osteoarthritis, chondrocytes produce high levels of proteoglycans, which are glycosylated proteins, and type 2 collagen. At some point, however, something causes them to switch over to making a different type of collagen, which is type 1 collagen. Unfortunately, type 1 collagen doesn't interact with the proteoglycans in the same way as type 2 does, leading to an overall decrease in elasticity in the cartilage matrix, allowing it to break down. This stage usually takes years to develop. Eventually, because chondrocytes aren't able to keep up with chronic damage, they undergo apoptosis, or programmed cell death. As a result, the cartilage gets softer, weaker, and continues to lose elasticity, and it even starts to flake off into the synovial space as fragments called joint mice. This activates the type A cells of the synovium, whose purpose is to remove synovial debris, as well as immune cells like lymphocytes and macrophages, which release pro-inflammatory cytokines that cause inflammation of the synovium or synovitis. As the destructive process progresses, fibrillations form, which are essentially cracks or clefts on what used to be a smooth articular surface. If no treatment is provided, the cartilage will continue to erode away until the bones are exposed, allowing them to rub with one another, which causes bone hibernation, making it look like polished ivory. Now, the subchondral bone reacts to the articular damage by causing a hypertrophic reaction that leads to new bone formation at the joint margins called osteophytes, which make the joints look wider. The traumatized subchondral bone may also develop subchondral cysts, which are attributable either to osseous necrosis secondary to chronic erosion or to the intrusion of synovial fluid. Symptoms of osteoarthritis are high yield. The condition usually involves less than 4 joints asymmetrically. Regarding its location, injury typically occurs in weight-bearing joints like the knee, hip, or ankle. In the hand, unlike rheumatoid arthritis, it most often affects the distal interphalangeal joints, but the proximal interphalangeal joints can be affected as well. However, metacarpophalangeal joints are rarely affected. Individuals often experience joint pain that tends to worsen with activity and is much more pronounced in the evening. Additionally, there can also be joint stiffening, which lasts less than 30 minutes and gets worse with rest. This is called the gelling phenomenon because it occurs when the synovial fluid becomes thickened, like a gel. Other symptoms include joint instability, limited range of motion, and crepitus, which are crackling or popping sounds felt on joint palpation due to the bones rubbing against each other. On examination, the osteophytes might be seen as single subcutaneous nodules over the affected joints. When seen in the distal interphalangeal joints, they're called Heberden nodes, and when they're seen in the proximal interphalangeal joints, they're called Bouchard nodes. Osteoarthritis of the thumb is called rhizarthrosis. Now, because knee cartilage loss begins medially, individuals might have bowing of the affected knee. Finally, unlike in rheumatoid arthritis, osteoarthritis doesn't cause systemic symptoms. For diagnosis, if osteoarthritis is suspected, plain X-rays of the most symptomatic joints should be taken. X-rays generally reveal marginal osteophytes, narrowing of the joint space, increased density of the subchondral bone or osteosclerosis, which is seen as poorly defined areas within the bone that are whiter than the surrounding bone tissue, subchondral cysts, which are more common in osteoarthritis than rheumatoid arthritis, and joint effusions, or increased amount of fluid within the synovial compartment. Joint effusion of the knee is typically seen on a lateral radiograph as a well-defined, rounded, homogeneous soft tissue density within the suprapatellar recess. Blood tests are normal in osteoarthritis, but are required to rule out rheumatoid arthritis or any underlying disorder causing secondary osteoarthritis. If the individual presents with joint effusions, arthrocentesis and synovial fluid analysis can help differentiate it from other arthritides. In osteoarthritis, synovial fluid is usually clear, viscous, and has under 2,000 white blood cells per microliter. Treatment of osteoarthritis can involve non-pharmacological approaches like losing weight or moderate exercise, as well as physical therapy. This can be especially important when large weight-bearing joints like the hips and knees are affected. Pharmacological treatment focuses on reducing pain and inflammation, and it usually consists of acetaminophen and NSAIDs. If neither of these are successful, some people might benefit from injections of hyaluronic acid or corticosteroids into the joint, or may need surgery to replace the affected joint. Alright, as a quick recap. Rheumatoid arthritis is an inflammatory disease that causes progressive, symmetric destruction of at least 3 joints, especially the proximal interphalangeal joint, which leads to morning stiffness that lasts for more than an hour and improves with use. Extra-articular symptoms include uveitis, pulmonary fibrosis, and rheumatoid nodules. Diagnosis is based on blood tests showing RF and anti-CCP, and on X-rays, typical findings include juxta-articular osteopenia, soft tissue swelling, narrowing of the joint space, bone erosions, and subchondral cysts. The long-term treatment of rheumatoid arthritis is use of non-biological and biological DMARDs, while short-term is with NSAIDs and glucocorticoids. Juvenile idiopathic arthritis is an inflammatory disease that occurs in those under 16 years of age, and there are 3 main types. Oligoarticular arthritis, in which there are up to 4 joints affected, polyarticular arthritis, which affects 5 or more joints, and systemic juvenile idiopathic arthritis, which is also associated with systemic symptoms like fever, spiking rash, adenopathy, and splenomegaly. Diagnosis is clinical, and treatment involves NSAIDs, intra-articular corticosteroids, and DMARDs. Osteoarthritis is caused by mechanical wear and tear, and it affects weight-bearing joints. It causes joint pain that worsens with activity and stiffening that lasts under 30 minutes and gets worse with rest. Diagnosis is based on X-rays, which reveals marginal osteophytes, narrowing of the joint space, subchondral bone osteosclerosis and cysts, and joint effusions. Treatment consists of lifestyle changes and medications such as acetaminophen, NSAIDs, and injections of hyaluronic acid or corticosteroids. Going back to our cases, Jody comes in with a 6-month history of bilateral hand and wrist stiffness that lasts for more than an hour a day but improves with use. Examination revealed swelling, limited range of motion, and rheumatoid nodules, and blood tests were positive for RF and anti-CCP. Her symptoms, age, and the fact that she is seropositive for RF and anti-CCP is enough to make the diagnosis of rheumatoid arthritis. Still, an X-ray scan of the affected joint might be needed to assess severity and disease progression. Carrie, on the other hand, is a 60-year-old woman with a 1-year history of pain in the right knee that's worse with use and associated with stiffness, which typically occurs at rest and lasts for 15 minutes. Examination revealed Carrie is obese and her knee shows bowing and has limited range of motion. Blood tests in Carrie's case were negative for both antibodies. Now, given her age and the fact that she is obese, plus her symptoms and negative serology, we can easily diagnose Carrie with osteoarthritis. An X-ray scan would be needed in her case as well.
Maurice is a 28-year-old male who presents with a 2-year history of gradually progressive low back pain and stiffness. He mentions that the pain wakes him up several times at night and that the stiffness tends to be worse when he wakes up and improves as he moves. Examination shows mild deformity of the spine and hip, as well as tenderness over the buttock. Then you see Clint, a 63-year-old male who shows up with a red, warm, and swollen left knee, which hurts so much that he can barely walk. Clint tells you that the symptoms started a few days ago, after he tripped and cut his knee. His body temperature is 38 degrees Celsius, or 100.4 degrees Fahrenheit. X-rays are ordered in both cases, showing in Maurice's case, erosion of the sacroiliac joint. On the other hand, in Clint's case, X-rays look pretty normal, so an arthrocentesis is performed, revealing that synovial fluid is purulent. Based on the initial presentation, both cases seem to have some form of arthritis. But first, a bit of physiology real quick. There are many types of joints, including fibrous, cartilaginous, and synovial joints. Synovial joints, like those of the wrist, elbow, knees, shoulders, and hips, are mobile joints that connect two bones via a fibrous capsule that is continuous with the periosteum, which is the outer layer of bones. The fibrous capsule is lined with a synovial membrane, which has cells that remove debris and produce synovial fluid. This is a viscous fluid found inside the joint capsule which lubricates the joint. Together, the synovial membrane and articular cartilage form the inner lining of the joint space. Now, arthritis refers to a group of diseases that cause destruction of one or more joints. First, we have seronegative arthritis, which is called seronegative because there's an absence of both rheumatoid factor, or RF, and anti-cyclic citrullinated peptide antibody, or anti-CCP, which are commonly found in rheumatoid arthritis. Something specific to note is that seronegative spondyloarthropathies have a strong association with the gene HLA-B27, which encodes for a specific type of MHC class I molecule. Now, there are several subtypes of seronegative spondyloarthropathies, and you can remember them with the mnemonic PAIR, where P stands for psoriatic arthritis, A for ankylosing spondylitis, I for inflammatory bowel disease-associated arthritis, and R for reactive arthritis. Let's start with psoriatic arthritis, which occurs in some individuals with psoriasis, or with a family history of psoriasis. It's an autoimmune disease characterized by joint inflammation. Exactly what causes the immune system to go haywire and attack the joints is unclear. And although the HLA-B27 gene is linked to the disease, it's not enough to trigger psoriatic attacks on its own, and environmental factors like physical trauma or an infection seem to play a role as well. Now, it all starts with psoriasis, where skin self-antigens are seen as foreign. When that happens, T cells start releasing cytokines that recruit and activate other immune cells to release TNF, IL-12, and IL-23. This triggers keratinocytes and fibroblasts to proliferate, which leads to the formation of psoriatic plaques. These are red, raised patches with silvery scales made up of dead skin cells. In some individuals with psoriasis, T cells also go to the joints and trigger the activation of osteoblasts and osteoclasts, leading to joint erosion and ossification, which can ultimately cause arthritis and severe deformities. Now, arthritis usually occurs after the psoriatic plaques have appeared, but it can sometimes precede them, which makes diagnosis that much harder. For your exam, it's important to note that less than 30% of individuals with psoriasis develop psoriatic arthritis. Symptoms of psoriatic arthritis typically include pain, swelling, and stiffness of the affected joints. There are several types of psoriatic arthritis depending on which joint is affected. The most common one is the distal interphalangeal predominant type, which generally affects the joints nearest to the ends of the fingers and toes, leading to dactylitis, which is the inflammation of the fingers, also known as sausage fingers, and nail abnormalities like ridging or pitting. Over time, some individuals with distal interphalangeal predominant type can also develop severe bone erosions and finger deformities. In severe cases, this can evolve into another type of psoriatic arthritis, which is arthritis mutilans. In arthritis mutilans, extensive bone erosion at the fingers creates a telescopic digit appearance that results in a person having what's called the opera glass hand. Diagnosis of psoriatic arthritis involves an X-ray, which may show joint erosion and osteopenia. The most characteristic feature, though, is the pencil and cup radiographic sign, which arises from the periarticular erosions and resorption of the bone, making it look slimmer than the soft tissue around it, sort of like a pencil in a cup. Treatment of mild cases of psoriatic arthritis includes NSAIDs. In more severe cases, non-biologic DMARDs can be helpful, especially leflunomide. If both NSAIDs and non-biologic DMARDs fail, biologic DMARDs like TNF inhibitors can be used to stop the disease from progressing. Rarely, surgery is done to repair the damaged joints. Next, ankylosing spondylitis is a chronic spondyloarthropathy that most often affects young and middle-aged males, but its exact cause is unknown. One theory suggests an underlying autoimmune reaction, wherein T cells mistake type 1 and type 2 collagen in the joints as foreign. Now, ankylosing spondylitis typically affects the spine, making it really stiff. Characteristically, there's inflammation of the intervertebral joints as well as the facet joints. Remember that there are two types of joints between the vertebrae. The intervertebral joint, consisting of two vertebral bodies, between which lays an intervertebral disc, which is made of type 1 and type 2 collagen, and an outer fibrous ring, called the annulus fibrosus, and an inner jelly-like substance known as nucleus pulposus. And then, each vertebra also has 4 facet joints, one pair with the vertebra above and one with the vertebra below. Sometimes, ankylosing spondylitis can also affect the sacroiliac joints, between the sacrum and the hip bones, or the joints of the cervical and thoracic region. In any case, there's destruction of the articular cartilage, so fibroblasts are activated and they start to replace the destroyed joint with fibrin. Fibrin then deposits in layers to form a tough fibrous band around the joints, limiting their range of motion. Eventually, osteoblasts get activated as well, triggering a process called ossification. That's when the fibrous tissue at the joint edges within the annulus fibrosus and turns it into small bony outgrowths called syndesmophytes. Ankylosing spondylitis causes articular symptoms, such as morning stiffness and lower back pain, which is worse at night, lasts for more than 30 minutes, and improves with movement and exercise. Individuals may also have kyphotic deformity, where there's an excessive outward curvature of the thoracic spine, as well as limited range of motion in the spine caused by both fibrin deposition and by syndesmophytes. Things can get so bad that the affected part of the spine becomes completely immobile. If ankylosing spondylitis affects the sacroiliac joints, it typically causes lower back or buttock pain and tenderness upon palpation. And if it affects the cervical or thoracic region, it can cause neck or chest wall pain and stiffness. Ankylosing spondylitis can also present extra-articular symptoms like weight loss, fever, and fatigue. Other high-yield symptoms include uveitis and tendinitis. And because the ribs and vertebrae are involved in breathing, spine stiffness can cause shortness of breath due to impaired chest expansion. Another way ankylosing spondylitis can affect breathing is by causing restrictive lung disease, and specifically pulmonary fibrosis in the apical parts of the lungs. In the heart, it can cause aortitis, or aortic wall inflammation, leading to dilation of the aortic ring and aortic insufficiency. Diagnosis is usually based on an X-ray, CT scan, or MRI, which can detect erosion and narrowing of the joint spaces. Another characteristic finding is the bamboo spine, which is caused by the ossification of the annulus fibrosus on the outside of a straightened spine, giving it a hollow appearance. Finally, genetic testing for HLA-B27 can be done to confirm the diagnosis. Inflammation and pain from ankylosing spondylitis are usually treated with NSAIDs, like ibuprofen. Pain and mobility issues can also be relieved by exercise or physical therapy. Remember that these individuals also need frequent monitoring of their chest expansion. In more severe cases, DMARDs like sulfasalazine and methotrexate can be taken to control symptoms and slow progression. Moving on to the I in the PAIR acronym. Seronegative arthritis may also be secondary to inflammatory bowel disease, including Crohn's disease or ulcerative colitis. Inflammatory bowel disease, or IBD for short, is characterized by chronic gastrointestinal tract inflammation, as well as systemic symptoms like fatigue, fever, and unintentional weight loss. Extraintestinal symptoms can include arthritis, most often affecting the knee or spine, eye manifestations like uveitis and episcleritis, and skin lesions like pyoderma gangrenosum and erythema nodosum. IBD-associated arthritis should be suspected when the individual presents with gastrointestinal symptoms together with joint or back pain and stiffness. To confirm the diagnosis of IBD, an endoscopy or colonoscopy with biopsy is needed. Treatment often involves a step-up approach, where less potent anti-inflammatory medications are initiated, and if they fail, they're changed to more potent medications like corticosteroids. Then there's reactive arthritis, previously known as Reiter's syndrome. This is an autoimmune condition that typically occurs after a bacterial infection of the gastrointestinal or urinary tract. The most common microorganisms that are associated with reactive arthritis include Shigella, Yersinia, Chlamydia, Campylobacter, and Salmonella. An easy way to remember them is to think of the mnemonic shy chicks. These are all gram-negative bacteria, so they have molecules on their outer surface called lipopolysaccharides, also known as endotoxins, which produce a strong immune response. Just how exactly reactive arthritis develops is unclear, but it probably has to do with the way endotoxins react with the MHC molecules on a normal cell surface, making them appear foreign. Symptoms of reactive arthritis take up to 3 weeks to develop after the initial infection because the immune system takes a while to present foreign antigens and kick T cells into action. Symptoms mainly involve pain and swelling of a single large joint, like the knee. Less often, it can involve other joints like the ankles, hips, and small joints in the feet, or affect multiple joints. Now, besides joint pain, there are 2 other symptoms that are very high yield for this disease. When the urethra is involved, it can lead to urethritis, which can cause pain with urination. And when the conjunctiva of the eye is affected, it leads to conjunctivitis, which can cause redness of the eyes. This is the classic triad of arthritis, urethritis, and conjunctivitis that should help you identify reactive arthritis in your exams. So a helpful mnemonic is that these individuals can't see, can't pee, and can't climb a tree. Rarely, reactive arthritis can cause a skin rash called keratoderma blennoragicum on the soles and the palm, which looks like a vesicopustular waxy lesion with a yellow-brown color. And finally, if you have a cervix, there can be cervicitis, which will cause pain with sexual intercourse, called dyspareunia. Reactive arthritis is usually diagnosed based on a history of previous infection and a complete clinical examination. In arthrocentesis, the synovial fluid is usually clear and sterile, since the bacteria producing the endotoxin do not invade the joints. Genetic testing for the HLA-B27 gene is often positive. Finally, throat and genital swabs might be used to look for chlamydia. In terms of treatment, NSAIDs like ibuprofen can be used for symptom relief, and if this doesn't work, then corticosteroids can be given to dampen the inflammation. Alright, let's switch it up and talk about one final form of arthritis, and this is septic arthritis, also called infectious arthritis. This too is associated with an infection, but unlike reactive arthritis, it isn't autoimmune. Septic arthritis refers to any joint inflammation caused by a microbe that's actually invading the bones, causing damage. Now, there are various ways for bacteria to get into a joint. For example, it can spread from a pre-existing osteomyelitis or infection in the adjacent bone. It can also develop from hematogenous spread, meaning that bacteria from an infectious site elsewhere in the body might travel through the bloodstream and reach the joint. And finally, it can occur by direct inoculation, which is when bacteria reach the joint directly. This can occur as a complication of orthopedic surgery, or if someone happens to fall on some dirty planks of wood and a nail pierces through their knee. Now, there are two main types of septic arthritis: gonococcal arthritis, which is caused by Neisseria gonorrhoeae, that typically spreads hematogenously from an initial infection of the cervix, urethra, or pharynx. For your exams, remember that this is more common in sexually active adolescents. On the other hand, non-gonococcal arthritis includes all of the other pathogens, especially Staphylococcus aureus, but it can be due to multiple Streptococcus species as well as Mycobacterium tuberculosis and Borrelia species, which cause Lyme disease. Once bacteria get into the synovial cavity, they start destroying the articular cartilage with their toxins and attract inflammatory cells such as macrophages to the site. Macrophages then release cytokines such as interleukin-1 and TNF-alpha that recruit even more immune cells to the site of infection. These may include mast cells, which release histamine to trigger vasodilation and increase vascular permeability. The final result is an increased influx of blood and inflammatory cells into the area, which creates a strong inflammatory response. Moreover, because vascular permeability increases, fluid starts to leak out of the capillaries and accumulate in the joint space, increasing intra-articular pressure, which compresses the blood vessels that supply the joint. Ultimately, this leads to necrosis of the affected bones and cartilage, damaging the joint even further. And because it's an infectious process, individuals present with inflammatory symptoms. Most often, the affected joint is red, swollen, warm, and very painful. Sometimes, the joint's mobility might be limited, and individuals might develop a fever as well. Now, gonococcal arthritis typically affects multiple joints, and it's also accompanied by skin lesions like pustules, as well as tenosynovitis, which is an inflammation of the tendons. On the other hand, non-gonococcal arthritis usually affects a single joint, typically the knee, but it tends to be more severe than gonococcal arthritis. Diagnosis of septic arthritis starts with arthrocentesis. The important thing to keep in mind here is that typically there's purulent synovial fluid with a high white blood cell count, over 50,000 cells per microliter, positive gram stain, and a positive culture, which identifies the exact causative bacteria. In addition, imaging, including an X-ray, ultrasound, CT scan, or MRI, can also be very useful to see bone erosion and joint effusions, especially for hip and sacroiliac joints, where synovial fluid aspiration is difficult. Additionally, blood tests can be performed, and they usually show findings consistent with inflammation, like raised ESR, CRP, and leukocytosis. Treatment of septic arthritis typically starts with antibiotic therapy and pain medication. For suspected gonococcal infection, you need to know that empirical treatment usually consists of ceftriaxone, which can be switched once culture results come back. If there are concerns about resistance or chlamydia co-infection, the individual is given dual therapy with ceftriaxone and azithromycin. In addition, treatment may require joint aspiration and washout by either arthrocentesis or a surgical operation known as arthrotomy. Alright, as a quick recap. Psoriatic arthritis is an autoimmune process that causes a T-cell mediated attack of the joints in people with psoriasis. The most common type is the distal interphalangeal predominant type, which can cause pain, swelling, and stiffness in the affected joints, but also psoriatic plaques and hand deformities like opera glass hand. Diagnosis is based on a history of psoriasis, negative serology for RF and anti-CCP, and X-rays showing joint erosion, osteopenia, and the pencil in cup sign. Treatment includes NSAIDs and DMARDs. Ankylosing spondylitis usually affects the intervertebral joints, facet joints, and sometimes the sacroiliac or neck and thoracic joints. Symptoms consist of morning stiffness and lower back pain, which is worse at night, lasts for more than 30 minutes, and improves with exercise. Extra-articular manifestations include uveitis, aortitis, peripheral enthesitis, and shortness of breath. Diagnosis is usually based on an X-ray, which can detect erosion, narrowing of the joint spaces, and a bamboo spine. Treatment consists of NSAIDs, exercise or physical therapy, and in more severe cases, DMARDs. Seronegative arthritis may also be associated with inflammatory bowel disease, which is characterized by chronic gastrointestinal tract inflammation together with joint or back pain and stiffness. For diagnosis of IBD, an endoscopy or colonoscopy with biopsy is needed, and treatment involves anti-inflammatory medications. Reactive arthritis is when an infection elsewhere in the body, typically in the genitourinary or gastrointestinal systems, triggers inflammation of a single large joint. The condition can also be associated with urethritis and conjunctivitis. Diagnosis is clinical, with history and examination, and treatment is with anti-inflammatory medications. Finally, septic arthritis is caused by various bacterial infections. It can be gonococcal arthritis when it's caused by Neisseria gonorrhoeae, or, more commonly, non-gonococcal arthritis when it's caused by Staphylococcus aureus or some other bacteria. It usually affects just one joint, which presents with signs of acute inflammation like pain, redness, warmth, and swelling. Diagnosis requires arthrocentesis and imaging, and treatment includes antibiotics and surgical management. And finally, coming back to our cases, Maurice is a 28-year-old male with a 2-year history of progressive low back pain and stiffness. This is important since we know we're looking for a more chronic cause of arthritis. He says the pain gets worse at night and in the mornings, but improves with movement. The key clue is that Maurice presents deformity and limited range of movement of the spine and hip, as well as buttock tenderness. In addition, X-rays reveal erosion of the sacroiliac joint. Given this information, Maurice most probably has ankylosing spondylitis. Since this is a chronic and progressive disease, Maurice will need periodic evaluation. Clint, on the other hand, is a 63-year-old male with a 3-day history of pain in the left knee that's associated with redness, warmth, and swelling, and he has a fever. So, based on this, we're looking for something with an acute cause. The biggest clue is that arthrocentesis reveals a purulent synovial fluid, and together with his symptoms, Clint most likely has septic arthritis. Gram stain and culture of the synovial fluid should be done to find the specific pathogen before starting empirical treatment. Systemic lupus erythematosus, often simply called lupus, is an autoimmune disease where essentially any tissue or organ can be the target of inflammation. Often there are periods of illness, called flares, and periods of remission, during which there are few symptoms. The diagnosis of lupus is made when 4 or more out of 11 specific criteria are met. The first 3 have to do with the skin. The first is a malar rash, sometimes just called a butterfly rash, which is a rash over the cheeks that spares the nasolabial folds and appears after sun exposure. Second is a discoid rash, which is a chronic erythematosus rash in sun-exposed areas like the arms and legs that are plaque-like or patchy redness and can scar. Third is a general photosensitivity of the skin, essentially a catch-all category for other rashes that happen to sun-exposed areas, typically only lasting a couple of days. Lupus can also damage the inner membrane or mucosa of various tissues, so the fourth criteria is ulcers in the mouth or nose. The fifth criteria is serositis, which is an inflammation of the serosa, which is like the outer membrane of an organ or tissue. It can manifest as pleuritis, which is an inflammation of the lining around the lungs and chest cavity, as pericarditis, which is inflammation of the lining of the heart, or as peritonitis, which is inflammation of the lining of the abdomen. Now, in addition to pericarditis, it's worth noting that lupus can also cause inflammation of the myocardium, leading to myocarditis, or the endocardium, leading to Liebman-Sachs endocarditis, where clumps of fibrin and immune cells form vegetations on the mitral valve. The sixth criteria is arthritis, and 2 or more joints have to get inflamed to meet that criteria. The seventh criteria is evidence of kidney damage based on protein or cells in the urine. It's generally caused by lupus nephritis, which is a type of glomerulonephritis due to immune complex deposition along the glomerular basement membrane. Lupus nephritis can ultimately lead to end-stage kidney failure, which is the leading cause of morbidity and mortality among individuals with lupus. The eighth criteria is neuropsychiatric conditions like headaches, seizures, psychosis, and mood disorders like depression. The ninth criteria is having autoantibodies against blood components causing cell destruction and leading to conditions like anemia, thrombocytopenia, or leukopenia. The final 2 criteria have to do with having specific antibodies in the blood. The 10th is having anti-nuclear antibody, or ANA, which targets nuclear antigens. Now, a large proportion of patients with lupus have these, meaning this test is very sensitive, but it isn't very specific because it can be found in other autoimmune diseases. The 11th criteria is having one of 3 other autoantibodies. The first is anti-Smith, which is an antibody against small ribonucleoproteins. The second is anti-dsDNA, which is against double-stranded DNA and is often seen more during flares, especially in individuals with kidney involvement. These 2 are relatively specific for lupus. The third type of antibody is antiphospholipid, which is actually an antibody that's made against proteins that are bound to phospholipids. And it's less specific for lupus, meaning that it can also pop up in other situations. There are 3 types of antiphospholipid antibodies. The first is anticardiolipin, which can cause a false positive test for syphilis since anticardiolipin antibodies are sometimes involved in syphilis. The other 2 antiphospholipid antibodies are lupus anticoagulant, also called lupus antibody, and anti-beta-2 glycoprotein 1. Sometimes, because of these, patients with lupus develop an antiphospholipid syndrome, where the antiphospholipid antibodies cause a hypercoagulable state, meaning they're more prone to developing clots and having complications like deep vein thrombosis, hepatic vein thrombosis, and stroke. Now, lupus can also cause additional symptoms that aren't part of the diagnostic criteria. Systemic symptoms include fever, fatigue, myalgia, unintentional weight loss, and lymphadenopathy. There can also be vasculitis, which can manifest as palpable purpura, paniculitis, petechiae, skin ulcers, splinter hemorrhages, and livedo reticularis, which is where there's a lace-like purplish discoloration of the skin. Another vascular condition that can occur in lupus is Raynaud's phenomenon, which is where arterial spasm causes reduced blood flow to the fingers. It typically lasts for a few minutes, and the fingers turn white and then blue, often with numbness or pain. And then, as blood flow returns, the fingers turn red and feel like they're burning. Finally, lupus increases the likelihood of thromboembolic disease. Specifically, a blood clot can form in a blood vessel and then break away to plug up a smaller vessel in another organ, like the lungs, brain, or kidneys. Lupus can also cause activation of the complement system, and during a flare, it can cause consumption of complement factors like C3 and C4. So, in summation, if an individual meets the diagnostic criteria, they may have many of these additional findings as well. Next is laboratory testing. That includes getting a complete blood count and differential to look for leukopenia, anemia, and thrombocytopenia, as well as a creatinine level which might reveal renal dysfunction. In addition, it's important to get anti-nuclear antibodies, anti-double-stranded DNA, anti-Smith, and antiphospholipid antibodies, as well as an ESR and CRP to look for evidence of systemic inflammation. In addition, C3 and C4 levels and a CH50 can be obtained to see if there's an effect on the complement system. Now, because lupus nephritis is such a serious problem, a urinalysis should be done to check for it, and distinguish nephritic syndrome, which has faster evolution towards end-stage renal failure, from nephrotic syndrome. In nephritic syndrome, there's the triad of hematuria, hypertension, and azotemia with subsequent renal failure. Whereas in nephrotic syndrome, there's the pentad of edema, proteinuria, dyslipidemia, lipiduria, and hypoalbuminemia. More specific organ involvement may require additional studies. For inflamed joints, plain radiographs can show joint deformities, and an ultrasound might detect synovitis, or joint effusions. Chest x-rays may be done for a suspected pleural effusion, interstitial lung disease, or cardiac abnormalities, while echocardiography and an EKG can be done to look for evidence of cardiac involvement, like pericarditis, myocarditis, and endocarditis. An MRI may be needed to evaluate any neurologic deficits or cognitive dysfunction. Finally, a biopsy of an involved organ, mainly the skin or kidneys, is often helpful in confirming the disease or tracking its progression. The key goals of therapy are to minimize both damage from the disease and toxicity from medications. So, treatment is mainly aimed at preventing or limiting the severity of flares of the disease. To help prevent flares means being careful to avoid triggers like sunlight, certain foods and medications, and tobacco. So individuals can avoid sunlight exposure with hats and long-sleeved clothes, avoid certain foods, exercise regularly, quit smoking, use immunizations to prevent serious infections, avoid medications like isoniazid, hydralazine, and procainamide, and carefully navigate pregnancies. Treatment is based upon the severity of the disease. Individuals with mild lupus manifestations, which generally means only having skin, joint, and mucosal involvement, are given hydroxychloroquine or just regular old chloroquine. They sometimes also use non-steroidal anti-inflammatory drugs, or NSAIDs, and short courses of low-dose glucocorticoids, meaning less than 7.5 milligrams of prednisone per day. Individuals with moderate lupus involvement are defined as having significant but non-organ threatening disease, along with constitutional, cutaneous, musculoskeletal, or hematologic manifestations. These individuals usually respond to hydroxychloroquine or chloroquine plus short courses of up to 15 milligrams of prednisone per day. Finally, individuals with severe or life-threatening lupus manifestations with major organ involvement, such as the kidneys and central nervous system, are usually treated in the hospital with a short course of high doses of systemic glucocorticoids, meaning 1 to 2 milligrams per kilogram per day of prednisone. This can be supplemented with other immunosuppressive medications, like cyclophosphamide, azathioprine, or mycophenolate mofetil. This initial therapy is followed by less intensive maintenance therapy with a lower dose of glucocorticoids to keep them in remission. Unfortunately, some individuals don't respond to glucocorticoids or other immunosuppressive agents. In those cases, biologic medications can be tried, like belimumab, a human monoclonal antibody that inhibits the activation of B cells, or rituximab, a chimeric monoclonal antibody against CD20, which is found on the surface of B cells and triggers B cell death. Alright, as a quick recap. Systemic lupus erythematosus is diagnosed when 4 out of 11 criteria are met. These criteria are a malar rash, discoid rash, photosensitivity, oral or nasal ulcers, psoriasis, arthritis in 2 joints, renal involvement, neuropsychiatric conditions, hematologic conditions like anemia, leukopenia, and thrombocytopenia, anti-nuclear antibodies, or another type of autoantibody like anti-double-stranded DNA, anti-Smith, or antiphospholipid antibodies. To help prevent flares, individuals should avoid triggers. Mild lupus is treated with hydroxychloroquine or chloroquine, with or without NSAIDs, and short-term low-dose glucocorticoids. Moderate lupus is treated with hydroxychloroquine or chloroquine and short-term glucocorticoids. Finally, severe or life-threatening lupus is treated with short-term high-dose glucocorticoids with or without other immunosuppressive medications like cyclophosphamide, azathioprine, or mycophenolate mofetil. Unresponsive cases may be treated with biologic medications like belimumab or rituximab. At the internal medicine department, a 42-year-old female named Mary shows up. She complains of multiple skin lesions on the arms, chest, and back. She reports having these lesions for about 3 months. In the past, she had similar lesions. She reports morning stiffness involving her fingers and knees, as well as a history of multiple miscarriages. Blood tests revealed pancytopenia, as well as a very high ESR and CRP. She was positive for ANA and antiphospholipid antibodies. Meanwhile, at the emergency department, a 25-year-old man named Kyle shows up with flank pain and hematuria. He has a history of migratory arthralgias and photosensitivity. He was positive for ANA and double-stranded DNA antibodies, and also had low complement levels. Blood tests revealed very high ESR and CRP, as well as high creatinine, so a urinalysis was performed, showing proteinuria and red blood cell casts. Both individuals actually have very different presentations of the same disease, called systemic lupus erythematosus. This is a systemic, relapsing, and remitting autoimmune disease, where systemic means that essentially any tissue or organ can undergo inflammation, while relapsing and remitting stands for periods of illness, called relapses or flares, and periods of remission, during which there are few or no symptoms. Now, lupus develops when the person's immune system starts recognizing nuclear antigens of the body's own cells as foreign, and tries to attack them. Essentially, B cells start producing antibodies which bind to nuclear antigens in our own cells. Normally, these B cells are destroyed before they fully mature in a process called self-tolerance. But in people with lupus, this process is impaired. The antibodies released by these B cells form antigen-antibody complexes, and these complexes drift around in the blood until they deposit or stick to the vessel wall in all sorts of different organs and tissues, like the kidneys, skin, joints, and heart. Deposited complexes then initiate a local inflammatory reaction, which causes damage through the activation of the complement system, which, after a huge cascade of enzyme activation, causes the cell to burst and die. Eventually, this gets complement factors like C3 and C4 all used up. A very high yield fact to remember is that this is a kind of type 3 hypersensitivity reaction. Another high-yield fact is that because early complement proteins like C1q, C2, and C4 are all involved in removing those antigen-antibody complexes, individuals that lack any of these proteins are more likely to experience lupus. Now, many patients also develop antibodies targeting other cells, like red or white blood cells and platelets, leading to pancytopenia. This is considered a type 2 hypersensitivity reaction. Okay, the classic scenario involves a female of reproductive age, especially of African American or Hispanic descent. There are 11 key symptoms and findings you need to remember for lupus, and we can divide them into 4 groups. The first group are 3 symptoms that have to do with the skin. The first is a malar rash, sometimes just called a butterfly rash, which is a rash over the cheeks that spares the nasolabial folds and appears after sun exposure. Second is a discoid rash, which is a chronic erythematous rash in sun-exposed areas like the arms and legs that are plaque-like or patchy redness that's scaly and can cause severe scarring or hair loss. Third is a general photosensitivity of the skin, essentially a catch-all category for other rashes that happen to sun-exposed areas, typically only lasting a couple of days. The next group involves 2 symptoms affecting the membranes. Lupus can also damage the inner membrane or mucosa of various tissues, causing ulcers in the mouth or nose. Next, there's serositis, which is inflammation of the serosa, which is like the outer membrane of an organ or tissue. It can manifest as pleuritis, which is inflammation of the lining around the lungs and chest cavity, as peritonitis, which is the inflammation of the lining of the abdomen, or as pericarditis, which is inflammation of the lining of the heart. It's worth noting that in addition to pericarditis, lupus can also cause inflammation of the myocardium, leading to myocarditis, or the endocardium, leading to Liebman-Sachs endocarditis, where clumps of fibrin and immune cells form vegetations on the mitral or aortic valve. What makes these vegetations special is that they can be present on either surface of the valve, but are usually on the undersurface. The third group includes 3 extraglandular manifestations. First up is arthritis, and 2 or more joints have to be inflamed. The next one is evidence of kidney damage based on protein or cells in the urine. It's generally caused by diffuse proliferative glomerulonephritis, which is the most common and severe type of glomerulonephritis caused by immune complex deposition along the glomerular basement membrane. The test question might show you or describe a light microscopy image with diffuse thickening of the glomerular capillary walls with characteristic wire loop structures. Lupus nephritis can ultimately lead to end-stage kidney failure. A high-yield fact to remember is that end-stage kidney failure is the number 1 cause of morbidity and mortality among individuals with lupus, followed by infections and cardiovascular disease. The last one is neuropsychiatric conditions like headaches, seizures, psychosis, and mood disorders like depression. The final 3 are lab findings related to blood. One of these is having autoantibodies against blood components causing cell destruction and leading to conditions like anemia, thrombocytopenia, or leukopenia, while the 10th and 11th findings have to do with having specific antibodies in the blood. The next one is having positive serology for anti-nuclear antibody, or ANA, which targets nuclear antigens. Now, a large proportion of patients with lupus have these, meaning this test is very sensitive, but it isn't very specific, because it can be found in other autoimmune diseases. The final lab finding is having one of 3 other autoantibodies. The first is anti-Smith, which is an antibody against small ribonucleoproteins. The second is anti-dsDNA, which is against double-stranded DNA and is often seen more during flares, especially in individuals with kidney involvement. These 2 are relatively specific for lupus. The third type of antibody is antiphospholipid, which is actually an antibody that targets proteins bound to phospholipids and is less specific for lupus, meaning that it can pop up in other situations. There are 3 types of antiphospholipid antibodies. The first is anticardiolipin. The other 2 antiphospholipid antibodies are lupus anticoagulant, also called lupus antibody, and anti-beta-2 glycoprotein 1. Sometimes individuals with lupus develop antiphospholipid syndrome, where the antiphospholipid antibodies cause a hypercoagulable state, meaning they're more prone to developing clots and having complications like deep vein thrombosis, stroke, and recurrent miscarriages. Now, although it's not included in the 11 key findings, other types of autoantibodies called anti-SSA or anti-Rho can be present. The reason that these are important is that pregnant individuals with lupus who are also positive for anti-SSA autoantibodies are at risk of having a newborn with neonatal lupus erythematosus. This may classically manifest as congenital heart block, periorbital or diffuse rash, transaminitis or increased liver transaminases, and cytopenias at birth. Another type of autoantibodies not counting as a criterion is antihistone antibodies. For your exams, positive ANA and antihistone antibodies with negative anti-dsDNA antibodies is a clue for drug-induced lupus erythematosus, which develops as a reaction to certain medications metabolized by N-acetylation in the liver. You can remember these with the mnemonic SHIP, where S stands for sulfonamide, H for hydralazine, I for isoniazid, and P for procainamide and phenytoin. So, genetically predisposed individuals who are slow acetylators are at risk for drug-induced lupus. This is characterized by abrupt onset of lupus symptoms, like fever, arthralgias, and pleuritis. For your test, it's important to know that unlike idiopathic lupus, drug-induced lupus typically does not affect the oral mucosa, CNS, or kidneys. Now, because lupus can affect any organ, differential diagnosis can be difficult. Starting off from the skin, an important differential is dermatomyositis, which is an autoimmune disorder that causes muscle inflammation, leading to progressive muscle weakness and wasting. Individuals typically present with heliotrope or lilac rash, which is a pruritic, purplish rash that can appear on or around the eyelids. This rash is similar to the malar rash of individuals with lupus, but a key hint on your test is that it typically extends beyond the nasolabial folds, which is a region that's usually spared in lupus. On the other hand, individuals presenting a discoid rash may require a skin biopsy showing autoantibody deposition. Differential diagnosis includes skin cancer, psoriasis, lichen planus, sarcoidosis, or syphilis. The arthritis in lupus can be difficult to distinguish from rheumatoid arthritis. However, a key distinguishing feature is that the joint deformities in lupus are usually non-erosive, which can be seen on an X-ray. Serology showing the presence of anticyclic citrullonated peptides are more supportive of the diagnosis of rheumatoid arthritis and can help distinguish the diseases. Now, the term rupus is used to describe patients with overlapping features of both lupus and rheumatoid arthritis, which usually has serologies consistent with both diseases, as well as erosive arthritis. Individuals with Sjogren's syndrome may have the same extraglandular manifestations that can be observed in lupus. Also, individuals with Sjogren's syndrome often have Rho and La antibodies. The distinction here is that Sjogren's syndrome should also present with glandular manifestations like keratoconjunctivitis, sicca, and xerostomia. So, use that as a hint to distinguish between the two. Finally, cytopenias can be caused by a wide spectrum of diseases, ranging from hematologic to infectious and autoimmune diseases. In addition, sometimes serological results are misleading, since these autoantibodies are often positive in a wide variety of diseases. A particularly high-yield one is anticardiolipin antibodies, which are also present in people with syphilis, and that can cause a false positive test, and some cases of lupus may resemble the maculopapular rash of the palms and soles that's typical of secondary syphilis. On your exam, remember that treponemal antibody testing should be negative in lupus. The treatment of lupus often depends on the severity of the symptoms and what organ systems are affected. Hydroxychloroquine and chloroquine can be helpful for arthritis and mucocutaneous symptoms. Short-term low doses of a glucocorticoid like prednisone can be used in conjunction to treat acute flares with less severe symptoms, and high doses are needed for serious or life-threatening cases, often with other immunosuppressant medications like cyclophosphamide, azathioprine, or mycophenolate mofetil. Alright, as a quick recap, Systemic lupus erythematosus is diagnosed based on 11 key symptoms and lab findings. We can divide them into 4 groups: 3 for skin, 3 for blood, 3 extraglandular, and 2 mucosal related. For skin, there's malar rash, discoid rash, and photosensitivity. For blood, there's hematologic conditions like anemia, leukopenia, and thrombocytopenia, anti-nuclear antibodies, and another type of autoantibody like anti-double-stranded DNA, anti-Smith, or anti-phospholipid antibodies. For extraglandular, we have arthritis in 2 or more joints, renal involvement, and neuropsychiatric conditions. Finally, for mucosal, there's oral or nasal ulcers and serositis. Coming back to our individuals, Mary's multiple skin lesions on the arms, chest, and back are consistent with a discoid rash. She also presents with arthritis involving her fingers and knees, and she was positive for ANA and antiphospholipid antibodies, which in turn led to her multiple miscarriages and pancytopenia. On the other hand, there's Kyle, who has a history of photosensitivity, and presented to the emergency department with lupus nephritis. In addition, he was positive for ANA and double-stranded DNA antibodies. As you can see, these 2 individuals have very different presentations of what ended up being the same disease. So, for treatment, Mary should be treated as an outpatient with hydroxychloroquine or chloroquine and short-term glucocorticoids, while Kyle needs a more aggressive approach, getting in-hospital treatment with short-term, high-dose glucocorticoids, and he may get other immunosuppressive medications like cyclophosphamide.